All right, Sana, we are live now.
We are live. Yes. Good to go.
So Deep sir, good to go. Over to you.
Should I start?
Yeah, please.
Good afternoon, everybody. I bring warm welcome from Zydus. Life is a journey, and in this journey, we are indebted to those who have added value to our lives. Our parents gave us culture, but it is our guru who had given us knowledge and wisdom. Today, whatever we are in our professional lives, a huge credit goes to our teachers who have relentlessly worked towards our development. And today is the best day to pay our gratitude to them on this auspicious occasion of Teachers' Day. Today we have legends with us, teachers of teachers, who have brought enlightenment in the life of so many students. I am thankful to IHERA, Dr. Ved Prakash, Dr. Charudat Joshi, and Dr. Sanjay Shukla, along with the entire team of IHERA, to think of this program and conduct this program on this wonderful day, the journey of ART with mentors and gurus. And today we have mentors and gurus from all across the country along with us in this program. Thank you very much, sir. And I think that the entire medical fraternity will appreciate this wonderful idea which you have put in today to have so many legends on one screen along with us. It is my honor to introduce Dr. Ved Prakash, who does not need an introduction in this platform. Dr. Ved Prakash is Lab Director, South End Fertility and IVF from Delhi, have more than 20 years of experience in the field of ART and is President of ACE. And he has been actively involved in so many academical programs, research works, chapters, contributed to a lot of national, international journals, and conducting so many series of programs. It is my honor again to introduce Dr. Sanjay Shukla from Jaipur. He is Lab Director, Baheti Hospital and Shivani IVF and Fertility Center. And we have also seen Sir in so many academic programs. He is the Chairman Academic Wing of Academy of Clinical Embryologists and have been editor in a lot of newsletters and journals. Dr. Charudat Joshi, once again, a wonderful academician, hailing from MP Madhya Pradesh, and sir have been also an active brain behind the academic programs that we have seen in the last 2 years. Sir, thank you very much, all the three of you, to think of this program, ideate this program, and bring this wonderful presentation today. I think that the audience will be delighted and people are eagerly waiting to listen to their gurus and mentors. Thank you once again for giving Zydus this opportunity to conduct this event. And I now hand over the session to Dr. Ved Prakash. Over to you, sir.
Thank you. Thank you, Mr. Sudeep, for kind introduction. And good afternoon to all the friends and my teachers. The light of the world, the beacon in the dark, and the hope that gives us strength to survive is our teacher. Today we celebrate Teachers' Day, a day kept aside to honor the gifted soul who work every day to make sure that the future is bright for all of us. Today we have teachers who are going to share their experience. Let us welcome all the teachers with a big round of applause. Today's webinar theme is Journey of ART with Mentors and Guru. And we at IHERA, we thought this topic to bring all our teachers, experts in the field of ART across the world, across our India, and today they are going to share their experience and tell us about what they have done during this past years in India for ART. So I welcome all of you once again, and I want to mention here that today we have Dr. Sadhna Desai, who is teachers of teachers here, who is going to speak about journey of ART Indian scenario, what they have did in past over the years. And yes, again, I want to mention here that today we have Dr. Sona Malik also, who made me what you are saying me now today,
Huh?
whatever I am here is because of Dr. Sonia Malik. Thank you, ma'am. Thank you, everyone. Thank you so much. And once again, welcome to all of you.
Thank you.
Over
Thank
to
you,
you,
Ved,
sir.
sir. I would like to introduce Dr. Rahul Sen, who is currently working as Chief Clinical Embryologist in Neelkant Fertility, Jaipur, Rajasthan, Executive Member Academy of Clinical Embryologists, that is ACE, India, Executive Member ISAR Rajasthan Chapter, IFS Rajasthan Chapter, invited faculty of Amity University of ART Fellowship Program by Indian Fertility Society in the field of ART since last 13 years, published papers in national and international journals, reviewer of Journal of Reproductive Healthcare and Medicine, JRHM, member of ISAR IFS ACE Eshere. Welcome, Dr. Rahul Sen. Now, it is my honor to introduce Dr. Sanket Dhumal, who is alumnus of University of Mysore, MSc in Genetics. K. Shama, IVF as the Senior Clinical Embryologist and Head in Embryology Unit, ESRE Certificate Clinical Embryologist. Executive Committee Member of Academy of Clinical Embryologists, Scientific Committee Member, IHERA, Editorial Board Member of Journal JBRA Assisted Reproduction, Member of ACE and ESRE and Indian Science Program. His area of interest lies in cryobiology and male infertility. Welcome, Dr. Sanket Dhumal. And last but not least, Dr. Akash Agrawal, an alumnus of Osmania Medical College, practicing male infertility embryology since 2011, topper ESRE Clinical Embryology, Vienna 2019, actively involved in academic and has co-authored a book chapter. He is an active member of National and International Fertility Organization, ESRE, ISAR, IFS, ACE. Participated in multiple national conferences as faculty and conducted multiple workshops in andrology and embryology, including vitrification and IUI. Keen interest in male infertility treatment with surgical retrieved sperms. I would also like to introduce Dr. Paresh Makwana, sir. He is Chief Embryologist Center Head at Wings Group of Hospital, Ahmedabad, Gujarat, India, and other associated centers of Wings. He is expert in embryo biopsy, blastocyst biopsy has been done on over 4,500 embryos, oocyte and blastocyst vitrification, in vitro maturation and oocytes. You are team leader of IHERA, executive committee member of ACE, lifetime member of IFS, treasurer in IFS Gujarat chapter, editorial board member in Journal MSD Publications, served as freelancer embryologist in India and West Africa, trained national and international embryologist. Welcome, Dr. Paresh Makwana. Ved sir, over to you for the
Thank you so much, Deepak, for
Sanket,
kind introduction.
Sanket, we have
Very good afternoon to all, and on
Sanket.
behalf of IHERA, welcome to all for this wonderful webinar on September 5th, which is a Teachers' Day. So, without much delay, I would like to introduce today's first moderator. So it gives me immense pleasure and honor to introduce Dr. K.D. Nair, sir. Sir is MD and DGO and Diploma in Obstetrics from Ireland and FICOG. Sir is working as Senior Consultant and HOD at Akanksha IVF Center and Mata Chandan Devi Hospital, New Delhi. Sir is President-elect for IFS 2022-2022 and Convener for Education Committee, IFS 2018 to 2022 and Secretary.
I think there has been a network glitch, perhaps. Ved sir, if you can continue, please.
And Dr. K.D. Nair is Secretary General Indian Fertility Society 2016 to 2018, Chairman and Fertility Committee AOGD 2016 to 2018, and he has presented many papers in ASRM, and recently he received a Star Award in ASRM. Over to you, sir. Deepak, can you share that slide for Dr. Sadhana Desai introduction?
Sure, sir. Sir, are you able to see it?
Yeah,
Yeah, please.
it is my honor to introduce Dr. Sadhana Desai. In fact, she is a real mentor for all of us. She is the Emeritus Professor of Department of OB-GYN at Bombay Hospital Institute of Medical Sciences, Honorary Physician to Governor of Maharashtra, Visiting Consultant, Beach Candy Hospital, Visiting Consultant, Sir H.N. Reliance Foundation Hospital. She is the Director of Fertility Clinic and IVF Center, Bombay. She was the past President of Indian Society of Assisted Reproduction, 2008 to 2010. She was the past President of FOXY also, 2003. She is an undergraduate teacher from 1970 to 1990 and a postgraduate teacher from 1980 to 2009. I welcome Professor Sadhana Desai to give a talk on the journey of ART.
Can you hear me?
Yeah, ma'am.
Yes, ma'am. Yes, ma'am.
Why it is not coming?
Is the slide open in your system, ma'am? In your laptop? Yeah, okay. We can see your slides, ma'am. You can
Okay.
put it in full name.
So, Dr. Ved Prakash, Dr. Sanjay Shukla, Dr. Charudat Joshi, and friends. Before I begin my talk, I would like to thank Dr. Charudat Joshi for inviting me to give this presentation of 45 years of ART in India, my perspective. To understand the science, it is necessary to know its history. A thorough knowledge of history of ART in India will help in understanding the challenges we are facing today, and hopefully it will result in improved outcome of the future treatment. This is the photograph of Dr. Subhas Mukherjee, who has been credited with India's first IVF baby, Anupriya, born couple of months after the world's first IVF baby, Louis Brown, was born. Unfortunately, Dr. Mukherjee was far advanced in his medical research and his knowledge on reproductive biology than his fellow colleagues and scientists, and they rejected his claim of IVF pregnancy and they humiliated him. After this reported birth of IVF, in history of IVF in India, there was a silence of 8 years. There were no new news or reports of any more IVF babies being born, either by his colleagues, his juniors, or anywhere else from India. It was only after 8 years that India's first scientifically documented ART pregnancy was reported by joint efforts of Dr. Indira Hinduja, a professor at KEM Hospital and GS Medical College, and Dr. Anand Kumar, who was heading Institute of Research in Reproduction. This baby was born on 6th August 1986, and within 3 months, 2 more babies were reported from India, one by Dr. B.N. Chakravarti from Calcutta, and second was our IVF baby born at private fertility clinic. This baby today has grown up to be a pediatrician. She's an associate professor of pediatrics, and this photograph has been taken when she got married. Now, in these 4 decades, I have witnessed a lot of changes that have occurred in IVF in India. When we started an IVF program, some of you were not even born, I suppose, and the things were very primitive because IVF was just developing in India. We used to prepare our own water for media preparation. We used to do 3 times distillation of water. We used to prepare our own media and test its quality by mice experiments. Ours was a private fertility clinic. We had no animal house attached to our clinic. So we used to get Swiss mice from Hafkin Institute and breed them in our garage. So with the petrol smell, sometimes these mice would breed and sometimes they would not breed. And we had quite a bit of a problem to keep on doing our IVF at that time. That time, our ovarian stimulation protocol was also very simple. We used to give clomiphene citrate from 2nd day of the menstrual cycle to the 5th day. HMG, we would start from the 4th day. And since we had no GRH agonist or antagonist being marketed in India, we used to do 8-hourly urinary LH assays to find the timing of HCG, and we would pick up the eggs at odd hours of day and night, and that too laparoscopically. Soon things started changing. In 1988, we managed to get transvaginal ultrasound probe, and we stopped doing laparoscopic ovum pickup and started doing ultrasound guided ovum pickup. We also soon got GnRH agonist in the market, and so the life became easy. We could prevent the LH surge and we didn't have to do ovum pickup at odd hours of the day and night. Even the gonadotropin preparations slowly started coming in the market. First, we had only HMG available. Then we got purified HMG, then highly urinary FSH, highly purified urinary FSH. And now we are able to get even recombinant FSH and recombinant LH. So the ovarian stimulation protocol are now changed completely. Depending upon the patient's profile, we can use whichever drug which is suitable for the patient. The most important development in India occurred in 1994, 2 years after the world's first ICSI baby was born in India. The ICSI baby was born in 1994 by Dr. Firuza Parekh. And that opened up the treatment for male factor of infertility, and the indications for IVF started expanding. I am only going to show you which I think are important developments in the field of IVF in last 4 decades. Another important discovery was the embryo freezing technology improved. Vitrification has totally changed a lot of things in management of IVF. Indications have changed, newer stimulation protocols have come, and things have improved with vitrification. Because of vitrification, now it is possible to safely and effectively freeze embryos at various stages of development and also do oocyte freezing possible. That it is possible to do oocyte freezing. This has led to newer indications like fertility preservation. Fertility preservation for women with medical disorder like cancer who are likely to lose their fertility following treatment of cancer, and if they survive and they would like to have a baby, it will be now possible because of this freezing their oocytes by vitrification. The vitrification has brought in new protocols for clinicians like freeze all protocol, random start protocol, and duostim protocol. Also, there are rapid developments in molecular science, and that has led to better embryo selection. It is now possible to do pre-implantation genetic diagnosis of embryos in women at risk of developing abnormal offsprings due to hereditary genetic defect. Not only that, it is possible to do the PGTA with embryo biopsy or with non-invasive PGTA for ruling out aneuploid embryos. We also have in India time-lapse incubator, and even now few centers have artificial intelligence to screen embryo selection called Life Whisperers. So things are changing. Now you all are embryologists. I don't have to tell the advancements that are possible in embryology and in your laboratory, but I would like to stress upon what I have noticed in the public attitude and the society's perception of IVF. When I started my IVF, people were very skeptic about doing IVF and they would keep a secret. They didn't want the society to know that their daughter or daughter-in-law underwent IVF treatment. As a matter of fact, when my first IVF baby was born, the parents requested me to keep the identity of their daughter and secret and not to reveal it to the media or to the other fraternity, medical fraternity, because they said, if my community finds out that our daughter is IVF baby, nobody will marry her. Now today, IVF has received a lot of publicity. Today, IVF indications have expanded, treatment has become safe, success rate has improved, and there is increased advertisements by ART centers, as well as there is a media publicity of celebrities conceiving by ART. So in metros, at least what I find that the couples who want to have a baby, they think that ART is safe, quick, and standard way of conceiving. There is also another reason why the demand for IVF is increasing. That is because now in last 4 decades, I find that women are getting married late. Couples plan their conception late. In metros, I find they come and they are quite married. They come after 35 years saying that they would like to have a baby. Therefore, they seek quick ways of conceiving and they are concerned about the wife's age. And therefore, they say that let's do IVF and have quick conception. They have more faith in the IVF technology than in their body. I would like to tell you about a case report of mine, which I think everybody else has come across, and it is present all over the world because of late marriages. There was 32 years old woman who came to me after 5 years of marriage, and she said, "Doctor, I want IVF." I said, "Why? How long you are trying to conceive?" She said, "I'm planning for only last 1 year." But she said, my husband is remaining very busy. He has no time to have sex. We have only sex once a month. I go for follicular study, and only when follicle ruptures, I telephone my husband, and then he obliges me. Husband got fed up after a couple of months, and he thought it was simpler to do ART for quicker and better results. So this is quite common all over for the patients because they think IVF gives a lot of success. 2 years ago, I came across this news in Times of India. This was the survey carried out in Britain, and they found that sheer pace of modern life, stress, social media, less face-to-face interaction leads to steep decline among married couple over 25 years and over. And they find that there is many of them have no sex for at least 1 month. They have very infrequent sex. And therefore, I think that IVF is becoming more common. Also, what I find currently that number of eggs and embryo donation cycles are increasing. Because I think infertility is still a stigma in India. Adoption is not easy and not readily accepted by society. We are living in a male dominant society, and therefore the family easily accepts egg donation because they want the male partner to have his child for inheritance. And poor socio-economically couples are sometimes forced to accept embryo donation because it is cheaper to get embryo donation done. So I think there is a need for awareness of fertility preservation in India. Now, this increase in the third party reproduction has caused ethical, moral, and legal problems. There is a misuse of technology by few, and therefore the need for regulatory body has arisen, and there is the ART law is already in Lok Sabha, and maybe in next session we will have some regulatory body on people doing IVF. What I find in last 4 decades that we, although started 8 years after the world's IVF baby was born, today we are in clinical results of IVF on par with world results. Maybe we are lagging a little bit behind in the research, but clinically our results are as good as the other countries. Treatment today is available all over India, and there is mushrooming of ART centers because the people are demanding IVF, and there is a demand and supply going on. Unfortunately, there is still a shortage of trained embryologists. There were hardly any embryologists about 2 decades ago, but today all young embryologists are there who are very knowledgeable, and they are very good in their subject and very experienced in doing good the embryology work. However, compared to number of ART cycles that are being carried out in the world, number of IVF centers present all over India, the number of embryologists are still short. And what I find is there is a trained embryologist going into multiple IVF centers to do the IVF treatment. And that does affect the accountability. Ideally, we should have a very good, when there is a very shortage of trained embryologists, we should have a very big, very updated IVF lab in every city, and the IVF centers and the doctors should send their eggs and sperms in this laboratory for the fertilization and further treatment. If that would happen, then we would have chance to do some more research, papers would start coming. Maybe in future, this may be a future, I don't know. So changes are occurring in last 4 decades. I am very fortunate to witness all these changes because I believe without change, there is no innovation, creativity, or incentive for improvement. Thank you very much.
Thank you, ma'am, for a wonderful description of the journey of ART for last 40 years.
Yes, sir. Go ahead. We can hear you, sir.
Yeah, Doctor, your audience has any questions or any comments? Sajna Desai?
Okay. Thank you for
No.
inviting me.
I think here we can see Dr. Sonia Malik and Dr. R.K. Sharma is here. They can share their experience also. We have still time and they can interact with each other. Ma'am, can you please? Hello. Sir, do you want to
Yes.
say something? Yes, please.
Good afternoon, ma'am. Happy Teachers' Day.
Hi. How
It's
are you? Nice seeing you after a long time on the
it's my pleasure, ma'am.
Yeah.
And I'm the privileged one to be the first student in IVF.
I know. Those were the days.
I know, ma'am. And I'm really grateful, for life and beyond for whatever we have done, the training and upliftment of this specialty. Now, the question is in my mind. See, nowadays the patients are also getting smarter and smarter. So the eggs are being picked up by us. So I am responsible, you are responsible for the, genetics of the egg. But what about the male? Because he is giving the semen sample in a closed room.
Correct.
And if he has got something in his mind and he brings some other friend's sample and then sue you, sue the doctor, what should we do about that, ma'am?
See, it is very, very difficult. This is the reproduction and the complication in reproduction are going on for ages together. Let's be very honest. Even when there was no IVF, people, the wives used to come and say, you put somebody else's semen, my husband's semen count is very bad. He will not know whose sperms are there and I will become mother. So these things, non-ethical things do occur because the desire to have a child is very great in women. And men and women both, sometimes they give somebody else's sample, you will never know. So you have to take something in writing. Now the legal things are coming up. So you will have to take in writing and say, this sample which has been brought to me from outside belongs to my husband, and both husband and wife should sign it. You cannot control, you will never know what is happening.
Yeah, because he's like the patient himself is a clever chap. He wants to have a baby also and take a lot of money also from you later on.
Correct.
He has got his sample, but he brings a sample of his friend.
But exactly, but you have to take it in writing. That is what we have started doing. I don't know how many signatures I'm taking. Formally, I hardly used to take any signatures. For freezing, I'm taking signature. For when they bring the sample from outside, I take signature. I take signature saying that wife knows that this is a husband. I mean, you will have to do it because somebody will sue you other day. So we have to become very conscious about medical legal problems that occurs. The DNA testing somebody will do and say, this is not my baby. And all these things we have to be prepared. Because what is happening, there is a misuse of technology by patients and also by doctors.
Yeah. The doctors, if he has done wrong, so it's a doctor responsible. But now the patients are getting smarter, they know.
Correct. I agree with you. I totally agree with you. You have to be very careful. I think all of us will have to learn a little bit about the laws and how many signatures we have to take.
Thank you, ma'am.
Ma'am, Dr. Sonia Malik is here. Ma'am, can you please
Very much,
check?
madam. Thank you very much. Seeing you, it is indeed a very fortunate day for me seeing you twice today.
I know.
We were together in the Haryana meeting
I
in the
know.
and now here today. Madam, it has been, Dr. Sharma says he is fortunate to be your first student. Yes, because he spent a lot of time. But I can also say that I was a brief first student of yours, because as
Okay.
I mentioned earlier also in the morning seminar, it was your OPU that I witnessed for the first time. When I saw an OPU being done, it was in your clinic. And so you have been my teacher also, but I have been like Eklavya, just watched you and learned. I did
know.
not have the fortune of learning everything firsthand from you as Brigadier Sharma did. But yes, you have been our inspiration and teacher all these years. And not like I mentioned in the morning also, it's not just the medicine and the IVF that you have taught us. You have taught us to be good human beings. Your persona, your way of conducting yourself, your way of talking to your patients, we've learned all that from you. So IVF has been a great learning experience for all of us as doctors, because our teachers have been such that they have handed us over the best qualities and tried to make us good human beings. So I think that is a great thing that we have achieved, madam, through teachers like you. Thank you so much for being with us. Thank you so much.
Yeah, thank you. But I do think that we have to be more careful. However good you are, the things are changing. People are becoming more legal minded. They start doubting when the results don't come, you know. So many things are
This
changing.
has actually, what we have all noticing is that the compassion is going away, because the patient is actually trying to make us, more firm and stern, and trying to make it so legal that sympathy and compassion is somewhere going away from practice, because we are always scared something might happen, somebody may take action, legal action. So like you're saying very well, the number of consent forms that we are filling now, we were not doing 20 years ago. There was only one consent form, and now we have a big
Correct.
pile of consent forms.
Correct.
So things have really changed over a period of time, and I think that is a very, very well said thing that you're saying, madam. A word of caution to all of us.
Okay.
Good afternoon, madam. This is Charu here.
Oh.
Madam, Dr. Sadhana, madam, I just want to ask you means your suggestion about the training programs for embryology.
Correct.
See, you have done wonderful things for us from the past, and as Madam said, Dr. Malik said, and Sharma sir said, I was also one of the first visitors of your lab there when I started my career in embryology. and
all of you have changed so much, I can't recognize you all.
and Vijay was the first one who told me the basics of embryology.
Okay.
So I am really thankful to you. But as you said that there is a lot of requirement of embryologists. So I just want your view that how we can improve it, because although you have put so much of efforts, but I feel still we need a good number of institutes who can offer the embryology training, or some sort of the people who are already in the field, they should go for a bridge course kind of thing, or something like that has to be planned. So
I would suggest that your association should come forward for that. Your association should come forward rather than clinician coming forward for it.
But madam, to be very honest, we don't have the clinician support like you. There should be people like you also be there. Like I admire Dr. Malik madam also. She was also supporting us from the beginning. From very beginning, I'm seeing her. Sharma sir was there. Everyone is supporting, but then still we have to find out some way, I suppose, because it is now high time.
Correct.
We are doing so many cycles and we don't have.
Can I tell you, Charu, that this pandemic, COVID pandemic, has made now distant learning so easy. Now I used to find that the embryologists could never go abroad and learn what these people are doing. They would not know who would pay for them to go abroad, attend the conference, see what other. So some Some good centers would send their embryologists, but majority wouldn't get opportunity. Now, because of COVID pandemic, now you are having so many embryology, the talks from the international talks are there, which you all can attend. I think this has also, I'm sure you all have helped us what's going on all over the world as far as the embryology is concerned.
Yeah,
Correct, madam.
True.
Thank you so much, Sadhana madam, for that wonderful, journey of ART for the 4 decades in Indian scenario. And thank you so much, Naisa, for moderating the session. So, taking forward the session, I would like to introduce the next moderator. Yeah, it gives me pleasure to introduce the next moderator. So, dear senior and friend of mine, Dr. Bindu Chimota ma'am. So, ma'am is currently working as IVF scientist and consultant clinical embryologist. And MSc, she has done MSc, MPhil, and PhD in biochemistry and MSc clinical embryology from Leeds, UK. She's joint secretary for IFS Vidarbha chapter and presented 18 original research papers as first author and 45 as co-author at ASTRAE and ASRM, and won best paper in travel training award at ASRM 2013 and best poster video award at ASRM 2019, and published 8 original research papers in international peer-reviewed journals. And she is a reviewer for reproductive biology and endocrinology as well as JRG, and contributed 14 chapters to national and international books on infertility, and contributed an chapter on prestigious Elsevier book series, Vitamins and Hormones. Her major thrust areas of research remains follicular fluid metabolomics, endometrial receptivity, and reproductive endocrinology. She's been member of ASTRAE, ASRM, IFS, CISAR, ACE, and Nagpur Obstetrics and Gynecology Society. So welcome, ma'am. Over to you.
Well, thank you so much, Sanket, for that introduction. Am I audible?
Yes,
Yes, you're audible, ma'am.
At the outset, I would really like to wish all my seniors a very happy Teachers' Day. Dr. Sadhana ma'am, Dr. Sonia Malik ma'am, Brigadier Sharma sir, Dr. K.D. Nair sir. We seek your blessings. We may not have directly come to you for any teaching, but we learn from your experience. Thank you so much for always being there and guiding us throughout in all our endeavors. Okay, so with that, I would like to introduce our speaker, Dr. Rajvi Mehta. It is indeed a pleasure to introduce her. She is, I must say, a veteran in the field of ART, having been in this field for over 3 decades. She is an excellent orator, and she is an in-demand speaker at many conferences, including IFS Iran and ASTRAE Germany. She is the chief editor of the ACE newsletter of the Academy of Clinical Embryologists India. She is in charge of the IFS SIT on holistic medicine, and she is currently an academic consultant to Cooper Surgicals and scientific consultant to Trajecta Biomed. A true speaker for this Teachers' Day event because she has trained so many people in this field. Dr. Rajvi, over to you. Welcome, and we look forward to listening to you.
Thank you, Dr. Bindu, for the nice introduction, and thank you, Dr. Ved Prakash, for inviting me. And I'm really humbled and honored to be speaking amidst two stalwarts to speak after Dr. Sadhana Desai. It's indeed very, very honorable for me, and thank you for this opportunity. So now the topic that I've been assigned is quite interesting. It's not something we routinely talk about, and I've been asked to talk about paternal factors contributing to embryo quality. Now, we do know that today, and over the decades, we have seen an increase in the rise of male infertility. And today, I think all over the world, we attribute 50% of the infertility cases to the male. And this is primarily done on the basis of semen analysis. And basically, that still remains the base of all our assessment. And in most cases, post-semen analysis, we would categorize the individual into normospermic, oligospermic, esthenot, teratospermic. And in cases where there's an abnormal semen analysis, maybe if it is not so severe, one may attempt an IUI. But if it is, say, borderline or after failed IUIs, the treatment modality for these male infertility patients remains to be a conventional IVF, or in most cases, ICSI, or TESA, TESI, and accompanied by sperms procured from the testis and ICSI. So now the question I wrote with treated is that we are presuming that if we can get a sperm we have our battle won and we are going to get a pregnancy or at least good embryos. And that is why that remains the whole goal of embryologists. And that is also one of the reasons that even when we are doing a conventional IVF with the failure of total fertilization failure, many of us want to jump only on doing ICSI. Now, the question that remains is, when you have sperms from an abnormal semen sample, are they genetically normal? Now, we never ever come across a situation where all the sperms are abnormal, or at least all the sperms that we see are abnormal or normal. There's always a percentage, and this makes the whole scenario very tricky. And we're always looking at percentages of motile sperms, percentages of morphological normal sperms, and of course, the total sperm concentration. So when a semen sample is categorized as abnormal, as an oligospermic, astenospermic, or teratospermic, what does it indicate? Is it just that we are seeing less motile sperms or less morphological sperms? But if we can pick up a sperm from that, we are going to achieve a pregnancy. What about their chromosomal number? Would there be any kind of aneuploidy in the sperms from the semen sample? What about the integrity of the DNA? Would there be any kind of DNA fragmentation? Would there be any kind of mutation just because is the semen sample abnormality not associated with anything else? Is it just possibly a reflection of something else? And then what is the effect of utilizing sperms from these samples, either by IVF or ICSI, on embryonic development and embryo quality? So these are the questions that we ask. And then like I just said, do abnormal semen samples have abnormal sperms? So yes, when we're talking of percentages, but is there something more than just the percentages? And how are the embryonic development, embryo quality, implantation, miscarriage rates affected by sperms which have higher aneuploidy sperms or a higher incidence of DNA fragment in sperms? So looking back at the literature, I looked at the presence of aneuploidy in sperms from patients with subnormal semen samples. So it could be oligosteroteratospermic or only oligospermic or only teratospermic. And then we found that the sperm concentration is negatively correlated. So if the sperm concentration is low, we have a higher concentration of sperm abnormality from those cells. And this is further enhanced when there are morphologically abnormal sperms. However, you don't have a direct correlation to say that, yes, if the sperm concentration goes below X million per ml, then there is a higher incidence of aneuploidy. It is very variable, and the kind of aneuploidy is also variable, which chromosomes are affected. But however, there are greater diploidy rates in samples from, in sperms from oligosteroteratospermic samples, and the chromosomes that are studied, because, these, as you can see, the studies have been done earlier, and they have looked at specific chromosomes, and primarily it's found in chromosome 8, 12, 18, and 6 chromosome. And even in another study done by an Iranian group, they found that there is higher diploidy in sex chromosome from oats milk. So when we have an oligosteroteratospermic sample, we may be able to pick up what appears to be good sperm, but there is an all likelihood that this could be aneuploid. Then, okay, we are not only looking at one of the parameters of semen analysis, let's look at the total normal, morphological normal motile sperm count. And again, they found that in infertile men, the total normal morphological sperm count, if it's less than 2 million, then again, there is a higher risk of sperm aneuploidy and diploidy. And even when we are looking at sperms from the testis, from non-obstructive azoospermia cases, again, there are higher disomy rates, especially in chromosome 15 and the Y chromosome. So basically, an abnormal semen sample can be associated with aneuploid sperms. And that concern is, and quite a concern, because an aneuploid sperm is very rarely going to give you a healthy embryo. Again, there are other conditions wherein we may find chromosomally abnormal sperms present, when in males with microdeletions in the Y chromosomes, not complete but partial microdeletions. And obviously, if there has been a man who has fathered a child with a paternally derived aneuploidy, then there's a very high risk of the second child also being of that kind. And especially also in women who have had recurrent pregnancy loss, the problem could have been with the sperms. So what happens when we do ICSI? Yes, we look for the best looking sperm, and often morphology doesn't essentially match chromosomes. So we may have a normal looking sperm, but it could be morphologically normal appearing, but the chromosomal content could be affected. On the other hand, yes, if it is grossly abnormal, then maybe we know that the chances of abnormality in the chromosome is high. We may not pick it up. However, I would like to say, and therefore, if you have a sample which is a higher incidence of oats, or then there is a likelihood, because in all probability, there are more sperms which are abnormal than normal, and in all likelihood, we can pick up an abnormal sperm and go ahead with its injection. However, I would like to state here that the absolute numbers are not very high. So it's not that 50% of the sperms have aneuploidy, because if that was the case, we wouldn't have this many pregnancies and this many babies born across. However, when one compares the percentage with normal samples, then it is high. Even if it is 3 to 4%, as biologists, we need to be aware of this limitation. Although we need not be very paranoid or fearful of it, but we cannot close our eyes to what is happening, because aneuploid sperms would inadvertently lead to aneuploid embryos. And then what happens is that, supposing just now I have only stated that abnormal semen sample has the possibility or a higher incidence of aneuploid sperms. Now, what happens that if you're using a suboptimal semen, what happens to the embryos? We may not have studied the aneuploidy rates in the sperms themselves, but even when they found that when they did a PGD of blastocysts from oligospermic samples, formed from oligospermic samples versus normal samples, there was a 3 times risk of a sex chromosome aneuploidy. And again, this was seen earlier too, that when they did ICSIs with a TESA or a TESI sperm, again, there was a higher incidence of monosomies and trisomies in the embryos, in the blastomeres from embryos obtained with ICSI. So all in all, it tells us, yes, if there is an abnormal semen sample, there is a potential risk of aneuploidy. And naturally here they have gone to blastocysts, but in all likelihood, there would be an implantation failure or a pregnancy loss. And what happens with aneuploidy rates and ICSI outcomes? Like I said, in all probability, we could pick up a normal sperm or we could pick up an abnormal sperm. And even here, they found that there was an increased amount incidence of aneuploidy in cases of men who failed to achieve a clinical pregnancy in ICSI. So ICSI has been done, everything has gone well in the lab, pregnancy didn't occur. And then when there was a retrospective analysis, it was found that the percentage of aneuploid sperms in the ejaculate of these individuals was higher. So all in all, we do see that the outcome in terms of sperms, in terms of embryo development, in terms of aneuploidy in the blastocyst, and in terms in achieving a clinical pregnancy is affected when the sample is abnormal. And then we go a stage further. Implantation has occurred, but what happens in cases of unexplained recurrent pregnancy loss? And even in this study, they found that there is a higher incidence of aneuploidy in the sperms, especially sperm chromosomes, in sperm chromosome X, Y, and 18 in the embryos from those which were obtained from these kind of sperms. So basically what we find is that even unexplained recurrent pregnancy loss in a multicentric trial has been associated with sperm chromosome abnormality. As I said earlier, the numbers are not so high, so therefore it is not very scary. But yes, the incidence is high as compared to normal situations. Now, the other situation is what happens when there is sperm DNA fragmentation, and all of us working in this field possibly hear on DNA fragmentation at least once a month, and it's a highly debated topic, whether it's important, should we do it, should we subject our patients to it, or should we just go and subject the patients to antioxidants because we believe that DNA fragmentation is associated with oxidative stress. So here I would like to just reiterate the basics, that we know that the sperm chromosomes, the sperm nucleus has to undergo a highly compaction process because it has a long journey right from the testis to the epididymis, through the vas, to the female genital tract, and therefore it can be highly exposed to the external environment, oxidative stressors, which could affect the DNA. And nature has made the sperm so strong, so the sperm DNA is very well compacted. It is 1/6 to 1/20th of any somatic cell. So it's so well compacted. But if something goes wrong during the packaging of the DNA during spermatogenesis and spermiogenesis, then once the sperm damage has already occurred, there is in all likelihood the reversal may be very difficult because the sperm on its own will not have the repair mechanisms to repair the damaged DNA. However, we'll come to possibility of repair later on. And the strand breaks can occur. I will go in a little more detail a little later during this whole chromatin remodeling and the protemination, that is conversion of the histones to protamines during the process of spermatogenesis. Now, if fragmentation, if any of these processes are affected, then we have DNA fragmented sperms from the testis itself, which is not essentially due to any extraneous oxidative stress. However, post-testicular level also, there can be sperm DNA fragmentation, and this is something we are very familiar with. This primarily is induced by free radicals during the transition through the male reproductive tract. We do know that if the DNA fragmentation index is high, if there is a very long abstinence because the sperms are in the epididymis and the vas for a long period of time, again, men exposed to radiotherapy and chemotherapy, higher incidence of sperm DNA fragmentation, and environmental factors like pollution, smoking are well known. And this is something which can be to some extent regulated by the antioxidant therapy, etc. So these are the two reasons for DNA fragmentation. Now, again, is DNA fragmentation something which is very rare? No, there are millions of sperms in an ejaculate, and never do you come across an individual where none of the sperms are having DNA fragmentation. So it is not as uncommon, and even a fertile sperm donor has some level of DNA fragmentation in the sperms in the ejaculate. However, there is another backup factor. So even of these millions of sperm, even if a few percent have certain level of DNA fragmentation during the selection process in the cervix, in the cumulus, acrosome, possibly the fragmented sperms are left behind and the intact sperms finally make it into the oocyte. And add on, the repair mechanisms of oocyte repair mechanisms or other DNA repair mechanisms are active in the oocyte, and the oocyte is capable of repairing fragmented DNA. Obviously, it depends on the level of fragmentation. If there is extensive fragmentation, the oocyte also can do nothing. But if the oocyte is healthy and there is minor nicks, then the oocyte can repair. And therefore, we have a lot of backup in nature for overcoming errors that can happen during the process of the sperm production as well as during its transit. And therefore, it is not, that's one of the reasons that it becomes very confounding and confusing to draw a clear conclusion between sperm DNA fragmentation and fertilization or embryonic development rate, because it's not a linear relationship. There are various factors that come into picture, the level of antioxidants present in the seminal plasma, and also the age of the oocyte. And therefore, we cannot directly come to any conclusion in this case. So, however, if we look at the level of DNA fragmentation in infertile and fertile men, then one finds that the DNA fragmentation levels in infertile men in general is found to be much higher than in fertile men. And this infertile group consists of primary basis of semen analysis, and as I said earlier. And then if we look at DNA fragmentation and sperm morphology, and again, it's a very confounding thing because normal looking sperm can have fragmented DNA. For that matter, an abnormal looking sperm may not grossly abnormal, but mildly abnormal, because morphology becomes very subjective to the observer. There could be having normal DNA and intact DNA. However, if there is a gross abnormality, like the head shape is very abnormal, or the bent neck, then, or vacuoles which are seen in IMSI, then there is a high likelihood that these are fragmented DNA. However, this, unless it's grossly abnormal, is not essentially easily visible with the current methods of selection of sperms for ICSI, or primarily on the basis of morphology at the time of injection. And again, therefore, there is no direct correlation which has been found between DNA fragmentation and morphology of the sperms. Like I said, it depends at what level you are looking. And the problem is that when you look at a processed sperm sample for injection, for ICSI, you have a mix of both. You may use techniques which are available to have a higher concentration of morphological or intact DNA. But again, it's chance which sperm you're going to pick up, because at that point of time, one doesn't know the sperm that is being picked up for injection is having intact DNA or not. However, if there is a higher number of abnormal, the chances are the risk is obviously higher. Then if we look at the impact of DNA fragmentation on embryo quality, and as I write at the start, it's something which is very confusing, confounding, and people have their own experiences and very different results. So Sun et al. Reported that they could not see any correlation between embryo quality in samples with high DNA fragmentation, which is more than 30% of the sperm showing DNA fragmentation, or low DNA fragmentation. And they looked at it whether they were undergoing IVF-ICSI. On the other hand, Borges et al. Segregated the groups into low DFI group and a high DFI group. And they clearly say that in cases of low DFI, there is a better quality of day 3 embryos, and they have better blastocyst formation, which is quite high, and even a good quality of blastocyst. It's not just the development of blastocyst, but the quality of blastocyst. And blastocyst assessment is much easier, I would say, than embryonic cleavage stage embryos, because part of the hurdle of embryonic development has been overcome. And if you look at the implantation rates also, they are much higher. Now, the question is that when you have two conflicting reports, which one should we believe? So if I am a believer in DNA fragmentation, then I would definitely want to continue and look at the report from Borges. And if I'm an opponent of DFI, I would like to look at the report of Son. So what would one do is, and let's go a stage further and look at DNA fragmentation and pregnancy outcome in IVF versus ICSI. And they found that the clinical pregnancy rate in the ICSI group was found between the high and low sperm DNA fragmentation. That was different. And also the pregnancy loss rates were higher, miscarriage rates were higher when the sperm DNA fragmentation was high. So it is understood that if the DNA fragmentation is very high, then maybe embryonic development is affected. If it is, it would affect blastocyst formation. Ultimately, it would affect implantation. And even if implantation occurs, it would lead to miscarriage. However, the problem is, and like I said, we have the biggest confounding, but a good factor. So from a researcher's point of view, the confounding factor is an oocyte, but from a patient and a clinical point of view, it is nice that the oocyte has the ability to repair. And whenever ICSI has been done, even with high DFI, then the outcome of ICSI in oocyte donation cycles is not affected. Even the pregnancy outcome in oocyte donor cycles is not affected because the oocyte takes care of it. However, in non-male factor infertility, we don't see this advantage. And here, it is also one needs to bear in mind that oocyte donation cycles, the oocytes are from young donors. So that is why when there is a mismatch between the age of the male and the female, if the male is much older, but the female is much younger, then the pregnancy rates are high, even in moderate male factor infertility. So that is one of the reasons that many people proceed for oocyte donation cycles. Now it depends on which gamete is more important to the couple. Would they want a donor oocyte because of a slightly compromised male, or would they want a donor sperm for apparently healthy oocyte? And it's a difficult choice to make, and I think one leaves it to the couple. But it is also not advisable, to my mind, that if the female is apparently healthy, but not healthy enough to rectify the problem in the paternal gene, it is not fair to go for donor oocyte. But that's a point of view, and I think final choice remains with the patient. And so how do we interpret it? So we look at meta-analysis, series of studies that have been done. The literature has tons of papers. And again, you find that sperm DNA damage, they find this detrimental to IVF clinical pregnancy rate. Some people say that it does not affect. And then some meta-analysis also show different kinds of results. And one of the reasons is because the way we do the DNA and sperm fragmentation, DNA fragmentation tests are so varied. We are looking that we do agree that DNA fragmentation does affect embryo quality. The meta-analysis is not giving us any conclusive evidence, but the probability obviously remains higher when there's a high incidence of fragmentation. So if you have 80% DFI, we know the probability is very high to have abnormalities. But when it's in the 30, 40, 45 zone, that's where things become inconclusive. But the reason that we have this variability between the different studies is that assay which is used for DNA fragmentation. Some assays like the sperm chromatin dispersion just looks at the percentage of sperms which have DNA fragmentation. So it doesn't look at the intensity of DNA fragmentation, whether it's single stranded, whether it's double stranded, level of fragmentation, multiple fragmentation. And some actually look at the level of fragmentation. So if you're looking at the comet or tunnel, it gives you a different interpretation. And that is the reason we don't have a clear picture. But we do know that if it is very high DFI, it's better not to proceed with an IVF or an ICSI cycle because the outcome is not going to be what we would want it to be. Then the third case is where we're going to talk about the Y chromosome microdeletions. And we know that this remains one of the causes of azoospermia or severe oligospermia. Of the various AZF, the azoospermic factor A, B, C genes located on the Y chromosome, there have been pregnancies achieved even when there's a partial deletion of the AZFC gene. However, there are lower fertilization rates, poor embryo quality. So if you don't have good quality embryos, the pregnancy rates will be affected. But then if you're looking at pregnancy rates per transfer, yes, we find that there's no impact on the pregnancy rates. But how frequently does one go ahead with AZF deletion? But we need to bear in mind that yes, in severe oligospermia also, if there could be a microdeletion, again, there could be a pregnancy, but the chances are not so high. So now, how does this, what role does the paternal genome, what exactly happens during sperm DNA packaging, and what role do these situations that happens? So during spermatogenesis, the histones, which we know are the major proteins which give the chromosome its structure, are replaced by protamines, which are small, more basic arginine and cysteine-rich nucleoproteins. So this will help the chromatin condensation and DNA packaging. So these are basic amino acids, and these basic amino acids strongly interact with the DNA to bring about good packaging. Then what happens is that these histones are replaced by transition nucleoproteins 1 and 2 in the round spermatid. So simultaneously, as the process of spermatogenesis progresses to formation of round spermatids and elongated spermatids before becoming a mature spermatozoa, simultaneously there are changes taking place in the packaging of the DNA, wherein the histones are replaced by the transition nucleoproteins, and later these are replaced by phosphorylated protamines 1 and protamines 2 in the elongated sperm protamine. Now what happens is that this normally in conditions in an elongated spermatid, 20 or in a mature sperm, 10 to 15% of the sperm chromatin is bound to the histones, and the rest is to the TP1, TP2, and T1, P2. However, if this transition of histones to protamines via the TP1 and TP2 does not happen, then there's a persistence of histones in the spermatids. And this in turn would lead to, because the transition has not occurred, there'll be lack or even decreased levels of protamines. And this affects DNA packaging. And naturally, because the packaging is not good, these sperms are prone to strand breakage, which in turn, as we have just discussed earlier, have this whole sequel of events from impacting embryo quality to recurrent pregnancy loss. And even if the ratio, so it is not just conversion of histones to protamines, but even if the ratios of P1 and P2, if it is altered, then too it affects the packaging and in turn makes the sperm chromatin susceptible to DNA fragmentation. And these altered protamine levels affect DNA methylation patterns. And we know that these play a very important role in the gene expression of the sperm. And this in turn influences development. So if one looks at this chromatin organization and embryonic development, what we find though that in normal individuals, the P1 and P2 are present in equal quantities. However, in infertile men, the ratio is altered with more of P1 and P1 protamine and less of P2 protamine. Also, there is increased histone to protamine ratio itself. And if the histone to protamine ratio is between 6 to 26%, then is a higher probability of blastocyst formation. And in case there is a complete protamine deficiency, then it does affect embryonic development and the embryos get arrested at the 6 to 8 cell stage. And we all know very well that we do manage to get a good percentage of fertilized oocytes developing to cleavage stage embryos, but conversion of cleavage stage embryos to blastocysts is not very efficient. And this could be one of the reasons, could be the protamine transition from histones to protamine, or a protamine deficiency, or the ratios being affected. So it is very interesting that this is something which is coming from the sperm, which is affecting embryonic development. So in a very beautiful review written by Stacy Koleko and Denis Sakas, Stacy Koleko is actually a product of the National Institute for Research in Reproductive Health. And in this very nice review, they have explained how sperm chromatin organization takes place. Here are the histones which are present during the early stages of spermatogenesis. Then these histones are replaced by smaller TP1, TP2 molecules. And these are the transition molecules which later become P1, P2. And you have a very compact packaging of the DNA. Now, this any of errors that happen here, if this total conversion doesn't take place or the ratio of P1, P2 is altered, I have already mentioned that the DNA becomes more susceptible to fragmentation. And the fragmentation can occur because of extrinsic factors like the oxidative stress, etc. There could be even sperm aneuploidy that could have happened during the early stages of spermatogenesis. And there could be epigenetic modifications with methylation patterns changing. And so to summarize, if we were to say what is the paternal contribution to embryo quality, so if the sperm chromatin decondensation doesn't take place, then there is decreased fertilization. And that, of course, we all know that if fertilization failure occurs, it's primarily the cause of the sperm. However, and same thing happens when you do not have proper fertilization or formation of zygote, decreased fertilization rate, it could be due to immature chromatin, an altered P1, P2 ratio, and the presence of AZFC mutation. When we have the cleavage blocked at the 4-cell stage, it is again arrested. So it's basically a day 2 arrest which occurs, or in that or day 2 sometimes. It's again to do with the P1, P2 ratio of the protamines and DNA strand breaks, which could be a consequence of the altered P1, P2 ratio and sperm centrosomal defects. We may manage to get the embryo developed to the blastocyst, and the paternal chromosome could have influenced an altered cleavage rate. Again, it is because of either an AZC microdeletion, which is a very small number of patients, but it could be increased persistence of histones and not the conversion to protamines. When it comes to blastocysts, you may have a formation of blastocysts, but again, the embryonic development and progression of blastocysts or a good quality blastocyst could be affected by DNA fragmentation, skewed histone to protamine ratio, and altered P1, P2 ratio. So you understand that the basic understanding of the process of spermatogenesis and the packaging of the DNA itself could be affected, and the consequence could be arrest of embryonic development, failure of implantation, or recurrent pregnancy loss, or failure of implantation. So this particular visual summarizes the paternal contribution in embryonic development. So to conclude, I would say that paternal factors could be responsible for recurrent pregnancy loss, recurrent implantation failure. So by and not essentially always uterine or hormonal factors, because once we've transferred good embryos or good blastocysts, and if there is an implantation failure or pregnancy loss, we often only associate it with an uterine factors or endometrial factors, but it could be due to paternal factors. Even if we don't have a good blastocyst development rate or the quality of the blastocyst is compromised, it is not essentially due to laboratory or oocyte factors. Because if we have poor blastocysts, the fact is, oh, something could have gone wrong in the culture conditions. Well, if something could have gone wrong in the culture conditions, why only in this patient? So there is something which is far hidden in the sperm, which is responsible for poor blastocyst development. Not essentially, I'm not saying not due to laboratory condition, but not essentially due to laboratory conditions. And even embryonic development rate, embryonic arrest could again not essentially be due to cultural conditions. It could be due to something which is coming from sperms, which are from abnormal semen samples. So friends, to conclude, I would say that achievement of fertilization with ICSI, especially in male factor patients, does not indicate that we are going to get healthy embryos. And the purpose of a patient who is coming for infertility treatment is not to get a good fertilization rate. A patient is not happy with fertilization rate. We embryologists are happy that we have a high fertilization rate. We embryologists are happy we have a high embryonic development of blastocyst rate. For a patient, it makes no difference. They are looking for a live birth and a healthy baby. And I think, as Dr. Sadhana Desai said just some time ago, we need to be involved in more research to understand the male factor and these silent factors which could affect the outcome of IVF. It is very important that the basic understanding, basic sciences that have studied these things are applied, and we don't go on mechanically doing ART and being satisfied that our pregnancy rates are equivalent to that in the world. We should aim to understand and improve on that. So thank you, Ahira, for inviting me. And it's been a pleasure to talk on this topic. And as I said earlier, between two stalwarts. So thank you so much.
Thank you so much, Dr. Rajvi, for so eloquently considering each and every aspect of the paternal factor contributing to embryo quality. I believe there are three main things that go into this. One is the subjectivity of assessment, right from the simple semen analysis to the most complex of tests that we carry out. Second, I believe, is the heterogeneity in results. Due to lack of any standardized protocols, we yet do not have universal standardized protocols telling us about the test results. And finally, most importantly, that whatever results we get is a reflection of a complete sample. We are still not talking of a single sperm. So even if we get a result, it is a reflection of the sample, and we can never be sure which sperm exactly we are picking up. So unless we have a means to test an individual sperm and then go ahead, I mean, we may freeze samples from SOAT patients, we may freeze surgically retrieved sperm and then again try and use those. But then we can never be sure which one is going to cause more harm and the embryo quality. So yes, that is one factor. And I think it is compounded by the fact that, like you rightly said, our emphasis on you, as long as we can retrieve a single sperm, we are okay with it and we'll go ahead. So it is not just about fertilization, it is about the blastocyst formation. And one more thing that is of major concern, of course, it is not a part of this talk today, but not just the embryo quality of blastocyst formation. Eventually, we are talking about vertical transmission of this genetic factor. And are we, by doing such high-end techniques of maybe retrieving a single sperm and then going ahead, are we creating a generation of more infertile men? So that is a major area of concern. I think we all need to look into that as well. And I think Dr. Sanket had asked, can you comment something about the centrosome inheritance?
Ma'am, you have to unmute yourself.
Yes, I mean, centrosome is another topic of discussion on its own, but yes, it plays the paternal factor, and it's something which also needs to be looked at. I mean, it's more left behind in research studies, but we never, because we don't know how to routinely be doing it in our cases, but that's also a very crucial factor. So yes, I missed that out, I admit, in the talking of paternal inheritance. That's also a very important aspect of paternal contribution to embryo quality.
Okay, there is one more question from Meenakshi Dua. Can a patient with Y chromosome microdeletion, AFZC present can pass same condition to his male baby?
Yes.
Obviously, yes.
Yes. And that's, it's something which is having been there for a long period of time. When ICSI came in, and that's the first question I asked, that, we are going to, I'm talking of the mid-90s, that we are going to be doing ICSI, and, that these males would never have fathered. Are we transmitting down to the next generation? And the answer I was given is that, why are you so worried about it? If the parents can have ICSI and conceive a child, I'm sure 30 years later or 25, 30 years later, the child would also have ways and means. But yes, we are. And also another thing, whether this deletion is only causing a problem in fertilization or in causing azoospermia, or there are other things which we don't know about. So that's always a concern when there is a genetic transmission of something which is abnormal. But then I guess it's for the counseling to be done by the clinic, and also make sure the patient understands what they're heading for. But honestly speaking, I think the patients are so keen on becoming parents, it doesn't bother them that they're transmitting an AZFC partial deletion or complete or deletion to their male child. In most cases, I don't think they are really concerned about it.
Okay, so for now, we should rest assured that we have the technology to facilitate the patient from conceiving a child. Maybe 30 years down the line, they'll have more advanced techniques to take care of those things.
Yes, true.
Questions, Dr. Sanket?
I think that's all, ma'am.
Okay. So Thanks so much, Dr. Rajvi, once again. And thanks to iHera for inviting me and making a part of all these interesting events. Your concepts are really wonderful. Dr. Ved, Dr. Sanjay Shukla, Dr. Sanket, everyone associated with it. Thank you so much for inviting me.
Thank you. Thank you.
Thank you,
Sorry
thanks so
for
much.
overshooting the time
Thank
a
you so
bit. I
much.
didn't realize that. So anyway,
No, that's
I hope
fine,
I'm
that's
not
fine.
eating in Dr.
No,
Ratna's
no,
time.
but it was
No.
a very wonderful, excellent presentation, Dr. Rajvi.
Thank you. Thank you.
Thank you so much, Rajvi ma'am, for bringing all the pertinent contributive factors, and also, as you mentioned, the protein ratio, which is very important because we see out of 208 cell types in humans, there is the only cell where it is going to replace with the protamines, all the histones. So thank you so much for that wonderful lecture, and thank you so much, Bindu ma'am, for moderating. So without taking forward the session, now I would like to introduce the next moderator. So it gives me pleasure to introduce Dr. Charudat Joshi sir, who is MSc PhD and CAT from Belgium. Sir has done post-graduation in life sciences and special training in ICSI and IVF and sperm from Gen, Belgium, and special training for embryo freezing from KK Women's Hospital, Singapore, and done special training in LIH from Belgium, and also done doctorate in life sciences and executive committee member of MP and ISAR chapter, and executive member of MP IFS chapter. Sir has been served as past vice president as well as president for ACE, and sir is currently working as medical director at Genes India IIT Bank. Welcome, sir, and over to you.
Thank you, Sanket, for such a nice introduction. And it is again, I am taking this honor and privilege to introduce Dr. Ratna. That's what I can say about her, that she is a silent teacher. We heard about the mentors, and I believe that she is also one of the mentors from the beginning, which is silently teaching and teaching and teaching until today. She is teaching and enlightening the younger ones, younger generation in the field of embryology. So welcome, Dr. Ratna Madam. She is MBBS PhD, present and past appointments was, she is a Chief Embryologist, Institute of Reproductive Medicine, Kolkata, worked as research fellow in Cleveland Clinic Foundation, USA. She has a teaching experience, as I said, teaching FNB students since 2002 and working as faculty in ARD training program conducted by IRM since 1990. And working as a faculty in ARD training program conducted by IRM since 2003. Total number of chapters contributed in national textbooks, total number of publication in peer-reviewed international journals 20, and our current research interest is idiopathic male infertility and stem cell infusion. So over to you, madam, for the today's talk of madam is the innovations. What means ultimately in IVF lab, what we are looking for is improvement of success rate, and considering that we are keep on adding up the new gadgets, new things, new technology in our lab, and that's how we are trying to achieve. So definitely we will be enlightened by madam's talk on this, that what is the effects of add-ons in IVF lab, and over to you, madam, to listen about your views.
Thank you. Very good afternoon to all of you. Thank you, Dr. Charu, for your kind introduction. I am really thankful to the organizer iHera for considering me to speak on effectiveness of add-ons in IVF. We know that almost 34 years have passed since the birth of first human test tube baby, but still we are not happy with the outcome following IVF. So research works are going on to invent or to establish new product, new technique, new culture media for improving live birth rate. You know, IVF is a significant financial commitment for most. Everyone is trying to maximize their chances for success. It is true for the doctor, true for the patient, true for the ART clinic owner, the hopeless and helpless couples usually ask for anything else that might be helpful to achieve pregnancy. And the doctors or the embryologist, out of desperation, out of frustration, sometimes, especially when there is repeated IVF failure, when the couples are at the end of their reproductive age group, apply this anything else on them to achieve pregnancy. So these anything else or optional extras are add-ons in IVF. So add-ons are optional additional treatment during IVF used for patients' treatment additional to the standard IVF care with the hope of increasing live birth rate. But next. But before using an add-on, we need one thing, that is the evidence. Evidence for its safety, evidence for its efficiency, and evidence for its affordability. Next. Now for robust evidence, we need preliminary work on animal model, if possible on human embryo donated for work purpose, research purpose. Finally, well-designed randomized control trials and follow-up of all children born from the procedure. Next. Now, Human Fertilization and Embryology Authority developed a traffic light rated list of add-ons. Green color for add-on having more than one high quality evidence from RCT, such as intracytoplasmic sperm injection, amber color rated add-on having conflicting or inconclusive evidence from RCTs, such as pre-implantation genetic screening, time-lapse imaging, and sperm DNA fragmentation test, etc. And red color for add-on, in fact, there is no evidence found, such as assisted hatching, intramorphologically selected sperm injection, etc. Next. Now, I will discuss about some commonly used add-ons in the IVF lab throughout the world. These are sperm DNA fragmentation test, advanced sperm selection techniques, IMSI-PIXI, physiological intracytoplasmic sperm injection, advanced embryo selection techniques, TLI, time-lapse imaging, PGS, pre-implantation genetic screening, and mitochondrial DNA load measurement. Implantation enhancing techniques such as assisted hatching and inclusion of embryo glue or hyaluronate and adherence component in embryo transfer media. And in recent years, for better risk management and better outcome in IVF lab, two innovative techniques have been invented. Those are electronic witnessing system and artificial intelligence. Next. Now, to assess sperm DNA fragmentation, the tests are used: tunnel assay, comet assay, halosperm test, sperm chromatin dispersion assay, sperm chromatin structure assay, and 8-hydroxy-2-deoxy guanosine estimation when there is excessive DNA damage. Rajbi, my previous speaker, explained nicely that when there is high DNA fragmentation, rather extensive DNA fragmentation, and there is high chances of fertilization failure, or there may be embryo formation, blastocyst formation, but early embryo loss is very common. Even after ICSI, we have found it. It is from our own experience. And if the DNA fragmentation is more, even the oocytes from younger age group are not able to repair this damage. Next. These tests, the previous test I discussed, no one is superior than other, and these are used to detect treatment option or sperm preparation technique. Which treatment option or sperm preparation technique is better or contraindicated. And when there is high sperm DNA fragmentation, according to Rajbi, and I have the same opinion, sometimes we prescribed or we advised antioxidant therapy. We advise for changing lifestyle, avoiding some bad habit to protect the sperms from oxidative damage. Next one. Now, according to one study by Osman in 2015, higher live birth rate was found in men with low sperm DNA fragmentation compared with those with high sperm DNA fragmentation. But using of ICSI could not support this evidence. But from our own experience, we have seen when DNA fragmentation is very high, even we cannot get good result. There may be fertilization, embryo formation, and ultimately miscarriage. And other study also suggested insufficient evidence and not recommended sperm DNA fragmentation as a routine test. It can be done in selected cases. And according to one Cochrane study, low quality evidence suggested antioxidant therapy in male for safety from oxidative stress. Next. Now, advanced sperm selection test, these are used to improve fertilization before ICSI procedure, to try fertilization by sperms with high DNA and genetic integrity in order to improve implantation rate and reduce miscarriage rate. Next. These includes IMSI, PICSI, non-apoptotic sperm selection, by magnetic activated cell sorting system, sperm birefringence by using Polscope. When polarized light passing through the acrosome reacted sperm head, it looks opaque against black background. So it is useful. I have seen that when there is total asthenospermia, just to select sperm which are immotile but alive, and acrosome reacted sperm are alive. So to select sperm before ICSI, it is useful. Hyaluronic acid binding, Rajbi explained nicely that histone, the immature sperm containing histone in the nucleus, they are unable to bind with the hyaluronone on the oocyte surface. Rather, protamine in mature sperm are able to bind with the oocyte hyaluronone present over the oocyte surface. So to differentiate, we can use this test. RCTs have been done to assess only IMSI and PICSI. Next. No improvement was seen in clinical pregnancy rate when these methods were compared with ICSI. Next. Now, PICSI, for PICSI, significant rise in clinical pregnancy rate was observed in one study, along with significant reduction in pregnancy loss. But evidence showing limited experience, still in formative stage, no additional risk, and recommended in indicated cases after thorough counseling. That is important, especially in case of these repeated fertilization, repeated implantation failure, in case of recurrent pregnancy loss, low fertilization, etc. We can use this test. Next, advanced embryo selection techniques. We know that conventional morphological assessment may not always reveal the truth, and it may be the gametes, the embryos may be affected by the timing of assessment. There may be observer, it may be observer dependent, and we know that good-looking embryos may not necessarily be genetically competent, and vice versa. For more dynamic assessment of embryo and selection of embryo, euploid embryos, 3 innovative techniques have been invented. We all know that is, those are time-lapse imaging, pre-implantation genetic screening, and mitochondrial DNA load measurement. Actually, to identify developmentally competent embryos, embryos which are fitted for reproductive procedure, it is our aim nowadays. Next one. Now, time-lapse imaging, it is an innovative technique of embryo selection, we know, based on their development rate and morphological appearance. Effectivity, not missing important events during culture, we know, provide good quality control, having teaching applications, provide more information to the patient, and of course, it increases live birth rate. Next. 9%, 9.7% increase in clinical pregnancy rate compared to traditional culture and morphology assessment alone was reported by one study. But according to Cochrane review, insufficient evidence of difference in live birth, miscarriage, stillbirth, or clinical pregnancy to choose between time-lapse imaging and conventional incubation. So the future challenge for time-lapse imaging is to play best role in the IVF lab and to reduce implementation and consumable cost that is very high now. Next, pre-implantation genetic screening. It has been reported that cleavage stage embryo showed a high level of aneuploidy, and PGS select against these aneuploid embryos to improve live birth rate. But day 3 PGS is not effective because of limited accuracy of fish, limited availability of the genetic material, and moreover, chromosomal abnormality and mosaicism are at the peak of day 3 cleavage stage embryo. Next. Rather, comprehensive chromosome screening of day 5 biopsy trophectoderm cell is a better option to increase implantation rate, to decrease time to pregnancy, recurrent miscarriage, and repeated implantation failure. But low quality evidence due to small sample size, including good prognosis patient and some methodological problems. Next. 2 large RCTs are awaiting the ESTIM study and the STAR study. We are waiting for STAR study, which includes all IVF patients and using next generation sequencing on blastocyst biopsies. Next. Now, mitochondrial DNA load measurement. We know, I have no experience from theoretical knowledge that mitochondrial DNA load, high mitochondrial DNA load is associated with blastocyst aneuploidy and lower implantation rate, indicating metabolic stress in the embryo. But there is no evidence till now that embryos selected through mitochondrial DNA load measurement increases live birth rate. Next. Yes, inclusion of embryo glue and adherence compound in embryo transfer media. Fibrin sealant, it was used in media to reduce ectopic pregnancy rate and increase live birth rate after embryo transfer, but no significant importance was demonstrated. Rather, we have used hyaluronone containing media during transfer. You know, hyaluronone is a glycosaminoglycan. It is present in the female reproductive tract and it increases in concentration during pre-implantation stage. And hyaluronone containing media is viscous. It is compatible with the viscous uterine fluid. So after ET, there is nice dispersion of the embryos within the uterine fluid, within the uterine cavity, and that may enhance implantation and prevent expulsion of embryos. Next. But according to one Cochrane study, there was no high quality evidence for improvement in clinical pregnancy and live birth rate, rather slight increase in multiple gestation rate. And according to another study, no improvement in implantation rate, clinical pregnancy and live birth rate. So further RCTs are needed. Next. Now, assisted hatching. All of you know that assisted hatching is a procedure by which we can make a breach or a hole on the zona with the help of micromanipulator to facilitate implantation. It is used in case of repeated IVF failure, advanced maternal age, frozen thawed embryo, or when there is high FSH or prolonged use of higher dose of gonadotropin, etc., etc. But Cochrane review showed no evidence of difference between the live birth rate in assisted hatching and control group. And according to another study, significant increase in clinical pregnancy rate and multiple gestation rate but there was no evidence of difference between the live birth rate in assisted hatching and control group. And according to NICE guideline 2013, the assisted hatching was not recommended in routine use because it has not been shown to improve clinical pregnancy rate. Now, in recent years, two innovative techniques I already explained have been invented in IVF lab. These are electronic witnessing system and artificial intelligence. I have only theoretical experience, and these are used for better risk management and better outcome for IVF in IVF lab. Next. Now, electronic witnessing system is a modern day application in IVF procedure, especially in the lab when there is a mixing of biological these gametes, embryos may happen, and this system can improve traceability and minimize the chance of IVF mix-up. It is based on barcode level, silicon barcode that is injected in the oocytes or sperms, but that is a labor-intensive work and not properly validated yet. And another one, last one is radio frequency identification technology, using radio frequency identification tag that is used widely. It has two advantages. It prevents the embryologist from working on more than one patient's oocytes and sperms at a time, and prevents the embryologist from omitting key steps during their routine culture. Therefore, definitely electronic witnessing system can improve the efficiency, efficiency and the safety of the IVF lab, and can increase the peace and confidence of the laboratory staff by reducing the time required for witnessing and by minimizing the interruption. Next. Yeah, another innovative technique in recent years in IVF to evaluate key steps more accurately. Actually, artificial intelligence is being tried to be used in IVF lab to improve and automate embryo ranking and selection procedure by extracting the relevant information from embryo microscopic image. And it is used to identify the competent oocytes, empty follicle, and Rajbi just now explained that good-looking sperm may have abnormal genetic integrity, but artificial intelligence can detect the sperm with high DNA and genetic integrity. And moreover, it can detect sperm cell easily in microsurgical testicular tissue. But use of artificial intelligence in most IVF center is not yet a reality. Next, because the problems being faced currently, different AI techniques are being proposed to be used in routine work of ART center that creates some uncertainty. And local lab conditions such as the method of embryo scoring, the type of incubator, the type of culture media, the type of ovarian stimulation protocol they are using, that may have a significant impact on data interpretation. And how artificial intelligence will perform with data it has never seen before, that is a big question. And AI algorithm developed by one ART clinic may not work equally well with the other ART center, for other ART center. Next. So we have to, definitely some solutions will come, and uniform laboratory standard is needed to optimize AI techniques. That is difficult, but definitely we can achieve it. And inclusion of some important parameters such as patient age, then stimulation protocol, ovarian reserve, that may be helpful during data interpretation, and all AI models need to be calibrated on representative data. Next. Recently, Life Whisperer AI model, I have no experience, but using from theoretical knowledge, they are using machine learning tool, assess non-invasively and instantly the embryo viability and embryo euploidy using one single image, and assess implantation potential and clinical pregnancy 25% better than manual assessment, and reduces time to pregnancy by 15%. Next. Now, I have to mention, rather I should mention some add-ons in IVF other than those used in the laboratory. These are endometrial scratching used for enhancing implantation, intrauterine HCG infusion, lot of variations because of different dose, different timing of infusion. Then infusion of platelet-rich plasma or mononuclear cell. When there is thin endometrium, the vascularity is less, or there is unsatisfactory endometrium. I have seen that there is some improvement in receptivity or vascularity after using them in selective cases. Antioxidant therapy, yes, in some idiopathic male infertility, it is helpful. Then immunotherapy in IVF, such as using of steroid, aspirin, granulocyte, colony stimulating macrophage factor, etc. Vaginal probiotics, but no high quality evidence was obtained till now. So I can conclude as next. Add-ons were used in the past, are being used in present, and will be used in future to invent, to establish new technique, new procedure, or new product for further advancement. And to use add-on routinely throughout the world, more than one high quality evidence is needed. But well-designed peer-reviewed RCTs with improving live birth rate are the gold standard of evidence-based medicine or technique. It is the responsibility of the regulator or the EATIC clinic to disclose all the informations regarding one add-on to the patient before applying on them. But the doctors or the embryologist, out of their experience or experience from the friends, colleagues, neighboring center, sometimes they have to apply in some indicated cases to achieve pregnancy, because we should remember that the first IVF was an add-on to natural conception. Thank you.
Thank you, Dr. Ratna Madam. It's fantastic, elaborate discussion about the add-ons. But still the basic question remains same, that whatever add-ons you have mentioned here now, it is most of IVF centers running in our country may not have reached to that.
Yes.
So what will be your advice as a mentor, the very basic advice to all these centers, how they can stick to maintain the quality and high implantation rate or pregnancy rate without utilizing these add-ons? Should they go continuing with the present systems which doesn't require all this, or they can just keep on doing some changes in their present system so they can achieve it?
Honestly speaking, if we are just very much concentrate upon the patient characteristic, and we can improve our or maintain the optimum lab condition, and we are very much concentrate on the work in time insemination, in time assessment, then definitely we can just maintain the some standard result throughout the year. But still we have to discover something. For that, definitely we have to use something new, but we have to analysis the patient profile. We have to talk with the clinician. There should be a good relationship between them, good understanding between them. So in some selected cases, we can use, if the patient can afford, if there is no additional risk for the patient, then if the patient can afford, then we can use some add-on for the improvement of the result or for the betterment of the patient. But definitely it is not possible in our country for using electronic witnessing system or artificial intelligence immediately. But in that case, we should be very honest to refer the patient to the center where they have these facilities for the betterment of the patient.
Yeah, exactly. That is what I also heard from our respected Dr. Sadhana Desai Madam's talk also. She also mentioned about this, that instead of having all these high value gadgets in different places, which is not possible, why can't we have a centralized system where in all metros we can have some 4 or 5 facilities in different metros, where if patient is affording and patient want, can go there and get all things done as per the add-ons, whatever is available. And simultaneously that will give us a data also in Indian condition.
That will be
that how
helpful.
they are
Otherwise we cannot progress, we cannot proceed.
Yeah,
we have to use, yes.
Yeah, because we are seeing that every gadget, when it comes, again there is a small line written that the results are still awaited, it is not been validated. So how you can just get it implant, get used to it, and how you can apply it in your system.
Yeah.
So I think that is one of the possible ways of Sanket, is there any question for Madam?
No, sir. Currently, there are no questions.
Okay. So thank you, Madam, for your valuable time given to us and blessing us on this occasion of Teachers' Day.
Yes,
so,
yes.
So, yeah, thank you very much, Madam.
Yeah, at the end, I would like to pay my homage. I can see one of the respected teacher, Dr. Sonia Malik, Dr. Sadhana Desai, and so many other teachers. I like to pay my respect to all of them. Thank you.
Okay, Madam. Thank you very much.
We respect you so much ourselves. Thank you so much. Thank you.
Thank you. Thank you.
Over to you, Sanket.
Yeah. Thank you so much, sir. Thank you so much, ma'am, for that wonderful lecture. Yeah. So to proceed with, we'll be starting with the panel. So I think today we have an excellent panel where we have stalwarts, pioneers, and teachers of teachers. So I think nobody needs an introduction, but still I'll be introducing them very quickly. To begin with, Dr. Neelam Bapna. So she is a Miss and obstetrics and gynecology, and currently working as consultant gynecologist and IVF specialist at Shivani Fertility and IVF Center, Saket Hospital, Jaipur, Rajasthan. Welcome, ma'am. And next is Dr. Sanjay Prasad. Sir is PhD in Life Sciences and currently working as lab director at Bharati Hospital, Jaipur, and Shivani IVF and Fertility Center, Jaipur. And Sir has done his fellowship in biology of reproduction from Argentina. And Sir has served as secretary for ACE and also serving as vice president for ACE and chairman, academic wing chairman for ACE and editor for newsletter of ACE. Welcome, sir. And next is Dr. Ved Prakash, sir, who is MSc and PhD, currently working as lab director at Southern Fertility and IVF New Delhi, NCR. He has more than 20 years of experience in the field of ART and president of ACE and founder president of IHRA and elected member for Virtual Education Committee, Society of Study of Reproduction, SSR, and faculty in the various fellowships and MSc programs, and contributed many chapters and original articles. And welcome, sir. To begin with the panelists, so it gives me pleasure to introduce Dr. Sonia Malik, ma'am, who is DG1 MD and FICOG and FIIMS, and Madam is currently working as director and HOD for Southern Fertility and IVF. Madam has been recipient of many prestigious awards, like IMA Kanak Goyal Award, IMA Lifetime Achievement Award, ACE Lifetime Achievement Award, and Har Abhiyan Lifetime Achievement Award. And Madam has held a lot of positions in the past, like past chair for Infertility Committee FOXY, past president for IFS, and past president for Indian Menopause Society. And Madam has also serving as at various editorial board member and also past editor in chief for Journal of Middle Health and scientific collaborator at Reproductive Research Center, Cleveland Clinic, USA, and member of ICMR Task Force on Genital Tuberculosis. Welcome, ma'am. Next is Professor Dr. Kuldeep Jain, sir. So, is a laparoscopist and infertility and IVF consultant. Sir is working as a director at KG IVF Laparoscopy Center at Delhi, and founder, secretary, and past president of IFS, chairperson of Endometriosis Committee, FOXY, scientific committee member of board of directors of IFFS, and chairperson of International Exchange Committee, organizing secretary of IFSS, and he has held a lot of other positions, and executive member of obstetrics and gynecology in Delhi, member of guideline committee of ISAR, and author of a book titled IVF Techniques for Beginners, and recipient of Appreciation Excellence Award from IMA Rajdhani Gaurav Samman. Welcome, sir. And next is Dr. Brig R.K. Sharma. So, sir is a director at Ma Fertility unit of Ma Kamyaka Fertility Solutions Private Limited. He is an ex-director at an HOD of Institute of Reproductive Medicine and IVF Center, Primus Super Specialty Hospital, Chanakyapuri, New Delhi, and founder director of EIT Center at Army Hospital, Delhi, and Southern Command EIT Center at Command Hospital, Pune. And sir has been a postgraduate teacher and examiner at MUHS at Delhi University, examiner for fellowship in reproductive medicine, DNB, and recipient of Jagdishwari Mishra Award, FOXO, Chief of Army Staff Commendation Medal, and GOC Command Medal. Welcome, sir. Next is Dr. Ramesh Srinivas, sir. Sir is the director and principal embryologist at Carey Fertility Private Limited, and sir is founder president of ACE India, post director of MSc ART with Mysore University, and vice chairperson for ISAR Embryology, and scientific director at Narayana Health Hrudyalaya, and past president of ISAR chapter of Karnataka, and director for business development, IVF Precision, and ICMR expert committee member, ART Guideline and ART Bank. And welcome, sir. Next is Dr. Vijay Mangoli, sir. Sir is the laboratory director and fertility clinic and IVF center, Mumbai, associated with human IVF since 1986, and secretary general of ISAR for the years 2009 to 11, chairperson of embryology ISAR from 2014 to 16. Sir has contributed 21 papers in peer-reviewed journals and many presentations through national and international conferences, and contributed around almost half ton of book chapters in medical reference books, and recipient of Lifetime Achievement Award in 2017. Welcome, sir. Next is Dr. Alex Varghese, sir. Sir is a consultant embryologist and associated with Kraft Hospital, Kerala, and Ashta Fertility Group, Ontario, Canada, and adjunct faculty in Masters in Clinical Embryology by JSS University and JSS Gunashila IVF, Bangalore. And he has published many papers, and his research gate score is around 34.43, and his Google Scholar citation index is around 1721, and he has around 1827 citations. Welcome, sir. Over to moderators.
Thank you, Sanket, for this elaborated introduction of all the moderators and esteemed panelists. And it is going to be a sort of extempore panel, because we none of us rehearsed actually. And when Dr. Ved asked me to moderate this panel, because earlier our good friend Sarpreet was expected to moderate this, but when he asked me to moderate this thing, I asked, there are already so many talks on this topic in the same webinar, so what are we going to discuss? And he said, we are going to discuss about their experiences. So as Sanket mentioned, all our panelists are evidently experienced, and we are going to learn a lot of things from their experience. So I fondly welcome all my panelists and co-moderators, Dr. Neelam Bapna, Dr. Ved Prakash. As you can see, the stalwarts of our fraternity, Sanket has already introduced you, though they don't need any introduction. Everyone knows them well. So I hand it over to Dr. Neelam Bapna, because we would like to start with the clinicians first. And who else other than Dr. Neelam Bapna would be appropriate for this? Madam, please.
Yeah, good evening, all my seniors, Dr. Sadhana Desai, Dr. Malik ma'am, and all esteemed teachers and all seniors. And good evening to all my colleagues also. Good day to start Teachers' Day. I also respect you all. And yes, I thank you, Dr. Shukla, for inviting me for this session. So now coming to this, already Dr. Ratna has touched all these add-ons in improving the success of IVF, and we know all of us are struggling to improve the success of IVF and since long, and thereby these add-on methods are there. Someone tries this, other one tries this, and then there are after a few days that this is not effective and all this. So with this, all esteemed panelists will learn how in their practice they utilize these. Is there any improvement in success by using these methods? So first we'll be discussing about endometrial scratching. So it was thought that in scratching the endometrium in the previous cycle would generate some chemicals and would improve the receptivity. We all know that embryology has improved a lot. There are many improvisations in embryology, but the endometrial receptivity is still to be worked upon. So I open this question to all the panelists. What is their experience about endometrial scratching? Is it improving the success rate, or it is not? Are they using it also in every IVF, or after a few cycles failure, what they are using? So open to all. Dr. Malik, I'd like to answer you first about this.
Thank you very much, Neelam. And first of all, big thanks to official thanks to IHERA for having me here and making me a part of this. And interestingly, today in this panel, I'm the only pure clinician. My other two clinician friends are also embryologists. So they are clinical embryologists, and the rest of you are embryologists. So I'm the only pure clinician, and thank you so much for addressing this to me, as endometrial scratching is something that clinicians are doing.
Yes.
So, well, as far as I'm concerned, I am not a firm believer that endometrial scratching is going to improve the success rate. We are in my practice, we are using it selectively, only in patients where we find that the endometrium is not, it is thick when we are starting the cycle. And that is the only time I do advise a scratch or a biopsy. And of course, in my practice, we are very fond of doing an endometrial biopsy. So I stick to the old teaching of doing an endometrial biopsy before we start any treatment of infertility. Therefore, most of the patients have already had a biopsy, and hence we don't see any reason why we should be scratching the endometrium again, unless of course we find that the endometrium is thick. So I've never kind of used it as a method to, to do it for every patient. It's only selective.
Yes. Yeah, that's true, ma'am. Because many of the people were doing it for IVF failure for 2 to 3 cycles to 6 days when they are doing it.
Yes.
Any other comment from anyone?
Dr. Kuldeep wants to say.
Yeah, Dr. Kuldeep.
Thank you, Dr. Sonia, for starting the debate on endometrial scratching. When it comes to the outcome, it is very difficult task to prove whether it is helping you or not, because all patients, they are behaving in different way. And when we talk of add-ons which are recently introduced, it becomes more difficult to prove whether they are helping you in your outcome or not. But as you already said that you have been practicing endometrial biopsy in almost all patients, and that we have been doing for long, and many a times after taking biopsy in the next cycle, patient conceives, or doing after hysterosalpingography, next cycle patient conceives. So we cannot conclude whether the endometrial biopsy or hysterosalpingography has really helped in making the patient conceive. Same is true with endometrial scratching. There are many papers which have suggested that there is a positive outcome. There are many papers which have suggested it is not working. Okay. In my practice, again, because these are the patients where we are struggling to give a pregnancy, and these are the patients where I am taking the help of scratching. Not in all patients, as you suggested, that it is selective. So we are in our practice again very selective in offering the endometrial scratching, because we don't know whether it is going to help or not. Of course, over the period, we may be able to develop a evidence on that. But at present, the evidence is very, very poor. Still, we are offering endometrial scratching in some of the selected patients who have already failed. Primary procedure, of course, we are not using in all cycles. So that is our practice.
Brigadier Sharma, sir.
Thank you. I agree with both Madam Suman and Dr. Kuldeep Jain that it has to be done selectively. Now, which are the patients which are likely to be helped are the ones, which have, previous unexplained implantation failure, and despite good endometrium and blastocyst transfer. That is the patient where the scratching may help, before we do the transfer next time. And another word of caution is that, it has to be done in a very, very aseptic manner. Otherwise, if you do the scratching a cycle prior to the IVF cycle, you may change the microbiome of the, uterine cavity, which is becoming a big, issue now. So the thing is that scratching is indicated in a selective group of patients. And also it should be done very carefully so that you do not, alter the microbiome of the uterine cavity, which will further impact, your pregnancy rate.
Let me just share something that we have been doing. In patients where you have unexplained infertility, where you don't know what has gone wrong, you've transferred very good blastocysts and the endometrium was very good. So what we are doing is we are taking a biopsy in the failed cycle. In the failed cycle, before she gets a period or before she gets a withdrawal, we take a biopsy. And that biopsy tells us a lot of things. Suppose that biopsy is compatible, it's a gestational endometrium. Then it means that the endometrium and the progesterone had reached its effect. There was nothing wrong over there, no lag, and there was no endometritis. So, and if you find that it is a dysynchronous or disassociated kind of an endometrium, or there is a lag over there, then you know that you were not able to achieve that kind of a thing. So that way an endometrial scratch might help. But if you're going to do it just because, 22nd day or 23rd day before starting a cycle, it's not going to give us any, I feel it is not beneficial because if you're doing cycle after cycle and not giving a break in between cycles, it may be of value because you are scraping off the endometrium before taking the patient on to the next cycle. But if you're giving a break in between cycles, then I don't think it is going to help us much. That is why we have never incorporated it in our practice.
Yeah, it should not be done routinely, and if it has to be done, it should be done just prior to the cycle, because whatever the good effects, the growth factors which they say, they are lasting forever.
Recently, I have started looking at the failed cases, as you said. I am still analyzing the data in a few cases. The number is not very, very great. Previous cycle failed. Next cycle, we did the scratching and then transferred. Some of the patients, they do conceive, and they are going to conceive whether you are scratching or not. So until it is a large study, well-controlled study, such type of answer may not be coming. And the problem is most of the literature, they have not compared with the same set of patients.
Yeah.
So that's why it is very difficult to reach to the conclusion. But certainly, I am trying to have the same control, same patients, whether the patients are getting benefited in the next cycle by scratching or not. If we are able to pool the data, certainly we will be able to reach to some conclusion whether it is helping or not.
Great.
Dr. Sonia Malik, madam had brought up a very important point, doing, endometrial biopsy after the failure and studying the endometrium. After the failure, you may find there's a discordant endometrium. And sometimes, you may find evidence of inflammation, inflammatory cells which are present, or you may find, plasma cells which are present. And, something which you never expected, you make a result, and that helps in counseling the patient also.
Absolutely, absolutely.
Cycle has failed, and
Yes.
what better we can do the next
Caused it?
cycle.
What caused it?
Yeah.
So my question is very basic because I believe there are a lot of people who are novice or new in this field. So I would like to know the science behind this endometrial scratching.
What? That's what. What is the science behind it? Yeah.
Is it some sort of immunomodulation?
It is. It is. That was the idea. That was the logic behind it. That, see, just as we are doing, what are we doing when we are giving estrogens in the luteal phase? We are suppressing the LH, and therefore we are trying to synchronize the follicles. So when we are doing that, we are actually also causing an action on the endometrium. We are trying to synchronize the endometrium as well because of the effect of the drug that we are giving. And suppose we are just giving the GnRH agonists, just that, then we are down-regulating the entire system, including the endometrium and its receptors. So the idea was similar, that you just down-regulate everything, and therefore you get a very, it is not it won't be an atrophic endometrium, but it will be an endometrium which is quite basic. And hence you have to start working on a raw endometrium where it is hoped that as the follicle grow, the same way the endometrium is going to grow. So the synchronicity or the efficacy of the endometrium becomes better and the receptors are better. That was the idea behind it, but I don't think it works for everybody. Because there are so many subsets of patients, even within one disease. Within PCOS, there are hundreds of different types of PCOS. Within endometriosis, there are hundreds and different types of endometriosis. So their endometrium is going to be different. And therefore, you cannot have the same formula for all of them. That is why we haven't been able to get good results, as Dr. Kuldeep has said. So the basic idea was, yes, what you're saying is correct.
How it is working, actually there are many theories. One is immunomodulation, one is release of some favorable substances after scratching. Initially there were a lot of recent how it can work in the previous, if you are scratching in the previous cycle, how it is going to change the implantation milieu in the next cycle. That was a very big question, and that still remains. But because nobody has studied what is getting changed after scratching.
Yes.
There is no data available. It is all theoretical. It is going to release some of the substances which may favor in the next cycle, or you are providing, because in scratching you are not scratching whole endometrium. So getting a raw endometrium is not the idea. It is just stimulating or immunomodulating at one point of time, and that is triggering whole lot of chemical reaction. That is what theory is. But what chemical changes are being taken place, nobody knows. So
Dr. Shukla, the other thing is
there is a gap between the theory and the practical, and that we need to find out whether it is occurring or not.
The other thing is that even if you do find that there is an immunological dysfunction in the endometrium, how are we going to correct it? That is our biggest problem. Yeah. We do not know the solution for that. Many years ago, we were trying to see what happens when patient takes MTP pills. I did this on endometrium with a friend. And she was looking at the immune factors, and we found that the IL-10 is very, very high with the TNF alpha in the endometrium in these patients who have taken MTP pills, and this effect lasts for more than 6 months. After that's why, you know, now we say that we should do DNC and we shouldn't give them pills if we have to do this thing termination. So we did try to find out, but then if we have IL-10 high or if we have TNF, what are we going to do about it? We have no solution except to wait and watch, isn't it? So that is why I think we don't know how it acts and what we will do if there is a problem.
Yes.
This just reminds me, the early practice when we are doing the patients coming from Bihar. कि डॉक्टर साहब दलैया कर दीजिए उसके हो जाएंगे. So probably this दलैया, this scratching has come from Bihar.
Dr. Bapna, do you have any experience regarding endometrial scratching in your practice?
No, actually, when it references came, when it started, then I did some cases with endometrial scratching, few cases, but I didn't find any difference in success. So then I stopped. I'm not doing right now.
Right. So what I can gather from all the experts' views that probably there are no surrogate markers to define that yes, this endometrial scratching has done something, and ultimately what we can do is just, and again, I mean, I'm not sure because I'm not a clinician, but there must be some degree of injury that you make, like just a little scratching or some aggressive scratching, and they have different impact on the outcome. So I don't think there is a standardized practice in this field also. Right. So shall we move ahead, or do we have anything to discuss on this?
Yes, we can.
So what evidence we have? Dr. Bapna, please.
Yes, recently 2 Cochrane reviews in 2021 involving many of the RCTs, they all have come with conflicting evidence that is not, they are of poor quality studies, and the results are both ways. So data are not that good to make a opinion whether this endometrial scratching is worthwhile or not.
Right.
So these Cochrane studies are still saying that it is of no evidence to do it in routine practice, not to do it in routine practice. So this was the table that is showing conventional IVF and endometrial scratching, and live birth rate only 27% with conventional IVF, and a similar rate with endometrial scratching, almost similar rate, 27 to 32%. And the clinical pregnancy rate without endometrial scratching is 32%, and it is almost the same by 31 to 37%. And miscarriage, prevention of miscarriage by endometrial scratching in conventional IVF, it was 6%, while it is 4.2 to 6.8%. So you can see the data is almost same, the results are almost same. So it's difficult to say whether it is having any effect in prevention of miscarriage or improving the success rate. So it is not recommended to do it in each and every case of IVF. And then there are some side effects also, like there may be pain and some minimal bleeding. And as all of you said, that there may be chances of endometritis also. So to see whether it is effective or it may even adversely affect your cycle. So it is still controversial. Now coming to the role of GCSF in implantation, as I said that it is very difficult to see whether endometrium is receptive or not. It's very difficult to work upon it. So again, there came an era where everyone used to do GCSF for instillation in the uterine cavity to improve the success rate. So this add-on, what is it and why it is improved, how it improves, and are you people doing it in your patients? Again, this question is open to all of you. Yeah, Madam Sonia Malik, you be the first to tell us, please.
Yes, as you said, again, I mean, I'm sure you will be presenting the evidence, but again, the evidence is mixed because, it may not be helping in all the patients, and we are using it. Yes, we are using GCSF selectively in some of our patients where we find there is a persistently thin endometrium and we have no other ways to improve it. Estrogen is fine and the estrogen levels in the blood are fine, but still the endometrium is not responding. So in a hope that we may have a better response from the receptors, we do give a little bit of this factor. And in some patients, we do find a success. Again, as Dr. Shukla says, there is no standardized way of giving it. Many centers are using it differently on different days and different intervals. So whatever it is, some of the centers are claiming very, very good results, and the other centers are saying it is of no use.
So what is your protocol, ma'am?
Yeah,
How you are using?
We are only giving it if we don't find an endometrial response, and suppose after we have seen the endometrium. Say we have given the estrogen for a considerable number of days, 8 to 10 days, and we find that it is stagnant, it is fixed, or it is not growing, it's stagnating.
Yes.
So then we give it, and we then review the patient after 4 days, and then see if there is a growth. Then yes, it is responding. Then we don't mind giving another dose. But otherwise, we just give one dose. It should be enough. Patient generally, responds, and you have adequate amount of endometrium. That's
So do you think it improves, the endometrial thickness improves after giving? What is your experience?
Yes, it does. Not in every case, I said, but in many of the cases, I mean, we do find, suppose I've given it to 10 patients, I will find that there is an improvement in about 6 patients. They do.
And what about the success rate in terms of success rate?
I haven't looked at my data. I won't be able to give you the correct figures. But yes, we do find, again, as Dr. Kuldeep and Dr. Sharma had also mentioned, this is not the only adjuvant that we are giving. So we really do not know what is working.
Every cycle is different.
Yeah,
Yes.
we are giving so
We don't
many
know which test.
We are giving so many things to make it work. So we really do not know what has worked and
which one is working. Yes.
But as a primary endpoint, if we see that the endometrial growth has happened, then we feel that probably this has worked, and that is the reason patient is done well. So that is how that's all that I can say about it.
That is actually, what we are doing, you are following the endometrium very closely when you are progressing into the cycle, whether it is a fresh cycle or frozen thaw cycle. And that is the point when you are not very happy with the growth of endometrium, proliferation, as well as the blood flow. And that can be documented very nicely, the effect of GCSF and even PRP. They are working, they are giving you the assurance, basically, within the cycle, that yes, after infiltration of installation of GCSF or PRP, you are getting the improved blood flow. The rest of the things remain same. You have just added, and after 48 hours, if you see a better growth, a better flow, you seems to understand that this is working. Whether it is converting into the pregnancy, that is another area of research. But certainly, but you are looking at the endpoint is a good endometrium, triple line endometrium, going from A to B. Color and dices are changing. So it seems that these are working in at least in some of the cases. And my experience has been quite okay. We'll not say it is very great, but especially in those cases where you are struggling to get a very good endometrium, the rest of the things are okay. And in these patients, if you are having a good endometrium, whatever you do, whether you instill GCSF or not, it is not working. But in those cases where it is compromised, certainly you are getting a better result after instilling GCSF or PRP.
Correct.
Actually, it would work in cases of unexplained thin endometrium.
Yeah.
Your previous cystoscopy has been normal, and there is no history of a genital cox in this. Because those patients where have already fibros or a thin endometrium because of tuberculosis, in those cases it doesn't work at all. And secondly, there is one thing which is going on, whether it's to be given intrauterine or subcutaneously.
Subcutaneous.
So
Yes.
now the problem is that if you give it subcutaneously, the patients may land up with a lot of bone pains.
Mhm.
So they will give you a call. So I think that should not be done. It has to be given, it should be given intrauterine. Otherwise, the patient will give you a call in the night. The doctor, I've got a lot of bone pains, back pain, and in the spine and the legs, what to do. And if you're not experienced, you will not know that is the effect of because it is stimulating the the bone marrow,
Yeah.
and that is causing the acute pain. So one has to be a little careful, and then whether to keep on giving it after the embryo transfer, subcutaneously. I see some people do also. So I do not know, madam, what is your opinion about that?
No, never, never, never. I have not given it. I have not. We don't give it after embryo transfer.
Embryo transfer.
Again, like you said, the patient is very uncomfortable, and then you really don't know what is causing it. And especially after the embryo transfer, I think minimal intervention should be done as far as we are concerned, so that nothing goes wrong. That's what I feel.
Because some of them have severe bone pains, after subcutaneous injection.
Yeah, this is again a Cochrane review, and the conclusions of the author was because this uncertain whether the administration of DCSF improves ongoing pregnancy or rates or reduces miscarriage rates, and the studies were also very low quality evidence. But some low quality evidence suggests that DCSF administration may improve clinical pregnancy in women with 2 or more IVF failures. But the included studies had unclear allocation and concealment, and they were at high risk of performance bias. So again, poor quality evidence, but yes, few papers say that it may improve clinical pregnancy rates. And yes, we all are using DCSF in few selected patients. Right.
In whatever data I am having, it is promising. Basically, if you compare not doing anything and instilling, when you you look at in that point of view, then certainly there is some scope, and it is promising modality to improve, especially in those cases where we have done the correction, histoscopic adenolysis and all that, and after that there is improvement, and even the pregnancy rates are comparatively better.
So, what are your criteria of DCSF? Is it like IVF failures, repeated IVF failures, or thin endometrium? Like which cases?
Even in primary cases, when we are having a patient who is having endometrial defect, like we have corrected endometrium by histoscopic adenolysis. Even in grade 3, grade 4 assurance, in those cases, even in primary cycles, I use these adjuvants.
Yeah, if you find that endometrium is not good, then
So wherever the endometrium is defective, whether it is primary or secondary, I use these adjuvants.
So, sir, you were talking about also use of PRP, no? So, do you have any experience? Are you using PRP also for this?
Yes, and I have compared also the effect of PRP versus GCSF. I find PRP little better in getting the pregnancy rate as well as the endometrial corrector. So PRP works better in some.
What is your protocol of using? How do you use, and when you use, which day do you use, and how much?
Usually 10 to 12 days of priming with estrogen, and if we are not getting a good corrector of endometrium, we instill and see after 48 hours. Usually two sittings I give of whether GCSF or PRP.
So in the same cycle, then you do the
same cycle. In the same cycle.
Okay. Okay, okay. Ma'am, you have any experience
PRP,
about
yes,
using?
we are also using PRP, but
Yeah.
I'm not using it very frequently. The reason is
Mhm.
I really cannot say what is the reason. Yeah, you know what happens actually is when you're seeing the endometrium and when you call the patient, say for an ultrasound monitoring, all
Mhm.
along you've seen that she's doing well, and then you call her and you find now the endometrium has slowed down, it is not growing. So there and then you put in a GCSF. You don't have to wait and prepare and
PRP,
do all
yes,
the tests
yes.
and then do it.
Yes.
So there and then you do put in the GCSF. So because of the simplicity of the technique and availability,
Yeah, ready availability of
that is the reason.
PCSF.
Otherwise,
Yeah.
yes, like Dr. Kuldeep is saying, PRP is giving good results
Yes,
also.
yes.
I mean,
Yes.
but
PRP, I am planning in almost all cases which I have operated upon grade 3 and grade 4 endometritis. All patients goes for PRP. Rest of the patients are for GCSF. Like that is my protocol.
So do you add some activator in PRP?
No. We are just taking the blood sample, concentrating, separating the platelets and installing insulin.
Because there are a lot of people now in so-called market who are selling their products that they are using this activator and this is doing better than the others. So it's very confusing for many people who are.
actually, the thing is that, see, if you're using an activator for the skin, it is still all right. But if you're putting something into the uterus and you're not sure of its effect later on, or also on the progeny, I don't think we are justified in doing all this.
Yes, true, ma'am.
Long-term effects of PRP itself are not known. So therefore, I don't know how justified we are in all these things. But the lesser we use, the better it is.
Yeah.
So now, can we ask our embryologist friends also about any role of embryo culture supernatant infusion or injection of embryo culture supernatant? Are they supporting this?
Don't think anybody is using this. In my knowledge.
There are some papers, yes.
Madam, I believe it's the clinician who can answer because
yeah.
No, sir. Because if the embryologist will say that you can do this, then yeah, it's opinion of both.
Yeah,
true.
You can ask Dr. Vidya Mangoli and Dr. Alex.
So
yes.
No, I can only comment on this that see, we being the embryologist, but we have to do anything which has to be proved first on similar kind of animals. We cannot just think of something and then apply it to the humans directly because we just think that this may work. I think this is a very important lesson that all we embryologists have to say, because nowadays I'm seeing a lot of people doing anything is something that is really has to follow a protocol. That is very important in IVF because we have to always remember that we are dealing with human beings and we are answerable to the patient. We cannot just go on doing the things on our own. So from this point of view, there is no evidence which says that this kind of media, if you use it, that will boost the receptivity, because ultimately there are clearly two aspects. One is a good quality embryo and one is a good quality receiving endometrium. And when we hand over a good quality embryo to the clinician, obviously the homework about the endometrium is well done by the clinician from all the respects, because we don't have the detailed file of the patient, but the clinician studies it from all the angles, his previous cycles, his age indications, everything has been properly studied. And I think that is why this call has to be taken by the clinician. But as far as this part is concerned, I'm not convinced myself that this will work. So I cannot really comment that yes, one should do it or one should not do it. What you say, Ved?
I don't think it is very easy actually, because you are collecting that supernatant. How you collect that thing? Maybe that time during that procedure by collecting, you can infect the system also. So I don't think it is
correct. There is no standardized protocol.
Yeah.
More to it.
Dr. Alex can say something about this.
No, I do agree with Vijay and with what has been mentioned, because I have no experience on this line, and I don't think it is going to make any much difference, because even the nowadays, the culture, it is a droplet culture. So I think how much amount of media that you are going to get to instill on the uterine cavity, that's another thing. Yeah.
So can I, sir, please, may I use this platform to ask all these esteemed panelists about a few cases you must also be knowing. Ma'am, sir, everyone can answer. I had 3 to 4 patients who had, 2 of them had Turner, and they conceived by ovum egg donation in first go they conceived. Then they came again for frozen embryo, for the next issue for frozen embryo transfer, and 2 cases of hypo. So there also we did stimulation and she conceived in first go. Then she again came for the second child. In all these 4 patients, what happened when I did this preparation for endometrium, all these patients had some endometrial fluid. Like if I am giving estrogen, I am giving GnRH analog. If I am giving, because this Turners, I cannot give ovarian stimulation, so I had to use this estrogen. Then there was endometrial fluid in each and every cycle. Come about me, I have searched the evidence, I have searched so many references, and I don't know what to do in these patients, because first time they conceive, second time I'm preparing the endometrium, again and again its fluid is coming. So do you have any experience of this kind of patients, or any treatment you have? You can suggest me for these patients.
Yeah, Brigadier Sharma, sir.
Yeah. See, if you find there's a fluid which is coming again and again, and
Yes.
there is no hydrosalpinx in these patients.
No.
Yeah. So the thing is, nowadays we are going, into the microbiome in the uterine cavity and the viral infections in the uterine cavity also. The papers have come. So maybe if you give them antiviral, treatment.
But they all are the same kind of, like they were after frozen cycle. No, every first time they conceive, second time when they are coming to the second issue, and I'm preparing the endometrium, then this problem is coming. Like all are same cases. So I don't think the viral infection must be the common cause for all these patients.
Yeah. And secondly, as Dr. Asha Bakshi has mentioned, sometimes in a retroverted uterus, when the cervical mucus is too much and thin and watery, and those cases you find, in the retroverted uterus, you may find this uterine cavity. And for these patients, what I generally do is I ask them to do the nipple stimulation. And after stimulation, I do the TVS again after half an hour or so. And all the cases you find that the fluid has gone out.
Okay, that's a good thing.
And
overexposure of estrogen in the frozen cycle is one known cause.
Very common. Yes, that is true, sir.
Yeah, so that is one thing. But if it's still repeatedly you are having the fluid in cavity, it will be better to go inside do a hysteroscopy. And
I did hysteroscopy also. It was okay. And sir, in Turners, what to do? We cannot do without estrogen. How can we prepare the endometrium?
Anecdotal experience is that you have to tell them to abstain, because we aspirated that fluid and we found spermatozoa in that. So that also is a reason where, you sometimes find. So you have to tell them to abstain. That can be one of the reasons.
Okay. Now over to Shukla, sir. Yeah.
So I think this aspect is focused or targeted to both clinicians as well as embryologists. So Dr. Ved have few questions first, and then.
So that now earlier days in past we used to do day 2, day 3 transfer. Nowadays we are moving to blastocyst transfer because of our culture conditions have improved lots, and we have introduced many things in lab. So what is your opinion from clinician to that embryologist? First clinician, maybe ma'am or Dr. Brigadier Sharma, Dr. Kuldeep Jain can answer.
Dr. Kuldeep can answer first this time.
Sorry, I missed the question. Can you repeat?
Sir, day 2 versus day 5 embryo transfer.
In my practice,
Yes.
Yeah. In your
over the period, I have switched on to day 5 transfer in most of the cases. Previously, I was doing day 3 more and less of the day 5. But over the period, I have shifted in most of the cases. If there is a possibility to go to day 5, I usually go for day 5.
So how do you select for day 3 or day 5?
One is the number of embryos available on day 3. Second is the grading of the embryo. If we are having all good embryos, we can go for day 5. If we are having only 3 embryos, then usually we transfer on day 3. But now, recently, even in day 3, if we are having all good, we tend to go to day 5.
So it is about the quantity now. And what about the quantity and quality? And what about the patient? There is any indication for that for day 3 or day 5? How do you select?
Nothing specific as from the patient side. See, all of us are trying to give conception in first cycle. So that is the main criteria of selecting various intervention, whether it is embryo transfer or any other intervention, and that is how to decide that what best can be done in that particular cycle. So that is one criteria from the patient side, how best it can be helped. They can be
So we analyzed our data of day 2, day 3 versus day 5. And one, of course, we did not find much of a difference between and day 3. But specifically, what we also found was that in a poor responders, where the number of embryos is less and actually you are forced to do a day 3 or day 2 transfer, in those patients, the success rate was quite good even with cleavage stage embryos. It wasn't essential for us to go up to blastocyst in poor responders because they do well even with the endometrium seems to be receptive for day 2, day 3. So basically in our center, we are restricting it to day 3 if we have poor response. And if we have a good response, definitely we want to do a blastocyst transfer.
Yeah, see, we analyze the data. That is what I am saying. We analyze the data of previous 5 years, and when we switched on to the practice of going more in the blastocyst, and I found a little better conception rate in blastocyst. So that has changed. That's why I changed my practice on the basis of that. There are maybe different experiences. If we have very huge data, maybe it may not be that significant. But whatever analysis I had done in my center, I see a better conception rate, and that's why I switched on to that, especially in frozen cycle. In frozen cycle, my practice is usually I freeze them on day 3, and when I do the transfer, we take them to day 5. And in those cases where I am transferring day 3 in frozen cycle, and so the comparative rate are better in those cases where I am able to take them to the blastocyst. So that is another additional point which I am considering to take all patients for day 5.
Can I ask Dr. Srinivas, can you enlighten something on this topic? Dr. Srinivas.
Unmute, please.
Audio is on, no? Am I
Yeah.
audible?
Yeah.
Yes, because let me tell you my experience in embryology almost 30 years. We know how the medium is evolved. We have understood so much on embryo development in vitro. Today, we were able to take the embryo up to the blastocyst stage, thinking that this is very appropriate stage to do the embryo transfer in order to get good pregnancy. And what we are no, expecting, actually, I think all clinicians, stalwarts, big teachers are there, agree with me. Finally, what we have to look into, actually, what is take-home a message and a take-home live birth rate when you do the blastocyst transfer and day 3. And I am sure all panelists will agree that cumulative pregnancy doing the cleavage stage embryo transfer is almost equal to the pregnancy what we get transferring the embryo at blastocyst state. My worry is actually I've been having a different opinion on considering the embryo transfer in the blastocyst stage. Say, for example, on the day 3, you have 10 embryos, you are expected to get only the blastocyst 5% rate. Okay, sorry, 50% rate. You have 5 embryos to transfer. What happened to another 5 embryos? And it is understood that the embryo culture medium what we use is a suboptimal. All these embryos may not go to the blastocyst stage. I don't know why, because still research has to be there in this thing. But I don't know, many of the clinicians are like, I know, they're switching over to, doing the embryo transfer with the blastocyst trait. Okay, if they're good responder, obviously you'll get a good blastocyst trait. Poor responder, you can predict. So because ovarian reservoir from where you get a oocyte will decide what is the quality of the embryo is going to be. All you want to need is better quality control in a culture condition. Okay, that's what. But I am not for my personal opinion going by the evidence-based medicine. Actually, if I see the Cochrane report and all, I'm not for transferring the blastocyst. Okay, indicated patient, you can do it, but not for all.
What about Dr. Alex?
Yeah, this I agree with all the panelists regarding this day 3 versus day 5. As Srinivas mentioned, there is no difference in the cumulative live birth rate between these two groups. But one of the major thing, like I think in 2016, Appa Maheshwari and Siladitya Bhattacharya, they put a nice paper from HFA data, and they coined the term the fetal safety first. Fetal safety first. So there are several issues regarding the extended culture. Even Dr. Tom Fleming from Southampton, I think he was one of the speaker in our Goa meeting in ACE, a good worker on the epigenetic aspect. So he was also recently published on paper in Human Reproduction, and he has shown that in the mouse model, with the extended culture, the cardiovascular adversity is more with a male offspring when you are culturing transferring at blastocyst stage. And the metabolic adversity is more with the cleavage stage transfer. So there is a balance needed. And also, one of the recent survey that we did in India on ETs, we have seen that 60% people in India do around the blastocyst transfer. But you have to really see what is the real environmental condition in each of these laboratory across the pan-India. Are they really fit to do the blastocyst culture, putting the blastocyst up to 5 to 6 days? Because I can tell from my experience on the program associated here in India, we had a kind of a construction going in the hospital in our nearby place. So we stopped doing blastocyst culture since we've seen some kind of effect on the embryos for almost 2 years. Now, when we moved to the kind of another laboratory, as per the Cairo consensus, we again started with the blastocyst culture. But as Sonia Madams mentioned, only limited number to start with. So we have to be very careful about the type of culture that we are doing, and also depending on because we know that the gases that we get in India is not a good quality, and there is no gradation of medical gradation or anything, and many people use a pre-mixed gas incubators. So these are some of the issues that has to be taken care by the embryologist and the responsible persons before taking a decision on what to do.
Dr. Vijay, you want to say?
Actually, I'm audible, right?
Yeah, please.
Actually, I think I can say that we allow embryos to guide us to decide the embryo transfer day. Why I'm saying that? Because as an embryologist, I'm sure on day 2 you get a clear picture, at least an idea about how many embryos, what is the overall quality of the embryos, and are you going to get sufficient number of embryos to go to the blastocyst stage. Now we know that there is a marginal difference between day 3 and day 5 transfer, giving some advantage to day 5. It's slightly better results on day 5. But thinking that maybe with day 5 we can eliminate those embryos that might get arrested between day 3 and day 5. But here we are assuming that we are providing an equivalent alternative of the culture conditions to the uterine environment. But we have to keep in mind that the cultural conditions in the laboratory are static, whereas those in the uterus are dynamic. They can change. The uterine environment can change, and they have a slight upper hand as far as the repair mechanism is concerned or the corrections are concerned, which is not there in today's cultural conditions. So these things we have to consider. So when we do blastocyst transfer we preferred. This is to minimize the duration of the patient to becoming pregnant, obviously, so that we know that we are transferring the best embryo. So at least 50% of the part out of the 2, the embryo plus uterine lining, so we are taking care of. But when the patient is young, more number of good quality embryos are available. If the patient has any previous history of the miscarriage with multiple pregnancies, for surrogacy and for embryo donation, of course, we think that blastocyst transfer, putting single blastocyst or maximum 2 blastocysts, depending upon the patient's age, may improve the outcome of the patient. And day 3 always is preferred when suboptimum embryos are available for us, when we cannot decide, when we are sure that probability of getting blastocyst is less, either because of the clinical factors or because, as mentioned by Alex just now, because of any unexpected lab factors. So all these the factors are to be considered before deciding whether we are going to do the day 2 or day 3 transfer or day 5 transfer. But as rightly mentioned by Srinivas, cumulative pregnancy rates ultimately remains the same. If the basic embryo quality is good and you are transferring into the good uterine environment, patient is going to get pregnant.
So there is one Cochrane review on that. So in that, primary outcome was live birth and cumulative pregnancy rate. Secondary outcome was a clinical pregnancy rate, multiple pregnancy, high order pregnancy, miscarriage, failure to transfer embryos, and embryo freezing. The main result of 27 RCTs was the evidence was current to April 2016. Fresh cleavage rate was 20% and fresh blastocyst rate was between 32% to 42%. So there was no evidence of difference between the group in cumulative pregnancy rate, very low quality evidence, and no evidence of different quality the group in multiple pregnancy and miscarriage rate, but the quality of evidence was low. So we can move to next.
In this regard, Alex, I would like to ask you one question, because this review was done in 2016 and a lot of advancement is witnessed during these last 5 years regarding the culture conditions, regarding the understanding of media that we have, and of course the VOCs and all. And we have improved a lot, especially in West. You all already mentioned about the Indian conditions, but at least in West, because most of the studies that were included in the review were from the West only. So do you think this conclusion may change?
Is it for the fresh transfer, or you're talking about the freeze-all?
No, it was only about the fresh transfers.
Okay. See, the thing is that we are still, after the 45 years of the development in IVF, we are still, I think, groping to find out the right cultural cocktail and also find environment, the stress-free environment. Whether you can't say that Western environment is far better than what we see here. Because many clinics, even Western side also, they don't put a proper clean room kind of a thing. So it is there are so many factors are involved, but definitely you know that the blastocyst transfer has got a advantage because of synchronicity between these two. And second important thing is that you can reduce the number of embryo to be transferred, because our regulatory agencies in the Western side, because of the policy like insurance policy, they want to have a single embryo transfer as a guarantee thing by the clinic. It has to be below 15% or below 10%. Like in our Canadian program, it is very strict. We have to transfer only one blastocyst or maybe one cleavage stage embryo. So definitely we go with all cases with the blastocyst transfer. So these are one of the guiding force maybe on that side, guiding more towards the blastocyst transfers rather than the actual evidences maybe.
All right. So this one is also for
Alex, I have some
yes, Srinivas, yes,
points to be addressed here. See, basically, we need to understand by doing the embryo culture up to the blastocyst rate under controlled quality control condition. Okay, let us not bother about the Indian scenario.
We can't see your face. We can't see your face.
Okay, my video is on actually. Can you see now?
Video is on, but you're very high. Yes, better.
Okay. Now it is see because basically we need to understand whether by transferring the blastocyst will it increase the success rate, take home baby rate, live birth. That is what we have to look at. And whenever we are culturing the embryo up to the blastocyst rate, this is under the control. Let us not compare between the Western and Indian scenario. Even Indian scenario also, if you are planned to culture the embryo up to the blastocyst rate, you will have to keep all quality control. Our aim should be here, by culturing the embryo up to the blastocyst, will it increase the success rate, take home baby? That is the question actually. For that, so much been explained. Like Alex told, there are the policy. Yes, it is there is a policy. You will have to have a singleton. Then after that, you don't have a neonatal problem. It's country's policies because they need to put more budget on maintaining the neonatal thing. That's one thing. But our aim should be that will it increase? That is what actually. If it is increased, definitely we will all grow the embryo up to the blastocyst rate and do the embryo transfer.
See, one of the important thing is that people nowadays look for the time to live birth, because that is another important thing. So I think everybody want the things to happen faster. Yeah. So TT, that time to live birth is definitely it is better with blastocyst transfers.
Great. So again, very informative discussion. Related to this point of only is freeze-all policy. So why this freeze-all policy developed first? What was the idea behind this? Dr. Kuldeep Jain, sir?
I think this should be directed to Srinivas or Alex, because we are the follower. As a clinician, we are the follower. Whatever you people are developing.
No, why I ask this question, because it is most of the time I vouch for all my fellow embryologists that it is the clinician who says that we are going to freeze all. I'm not going to transfer in this.
I am not in that league, but I still believe
because you are partly embryologist.
Yeah, I still believe that freeze-all policy needs to be critically evaluated, and lot of discussions should be instituted before anybody go for freeze-all policy. That is my opinion. I am not very happy with the whether we go for blastocyst all or freeze-all policy. One needs to be individualized actually in their approach. So one thing cannot be applied to all patients, and that is true for freeze-all policy also.
Yes, I agree with you, because no freeze-all policy of course, we have really developed a very well vitrification method where we are able to get 100% recovery. But we need the same time, we have to understand we are exposing unwantedly these embryos, very good embryos, to the cryoprotectant, which is not, I say, is ethical. Okay. Okay, it is indicated you freeze up, no problem. Clinically, there is some indication. Let us not do the embryo transfer this way. But thinking that freeze all, no, you will get definitely next the embryo transfer pregnancy. I will not agree with that.
Yeah.
That is true. I also agree with this thought. But see, freeze-all policy, I think it is based on the assumption. It started all that the stimulation protocol might have some adverse effect on the uterine receptivity, and that is why we should not transfer the embryo into the stimulated cycle, but freeze it and then transfer it into the subsequent cycle. But we know it that this is not true in all the cases, because we have been getting pregnancies for decades in the same cycle transfers. So there is no need to understand. There is a very need to understand and precisely differentiate between likely affected and non-affected cycles. And generally, patient also prefers to finish a treatment cycle at one go, because he also comes and says that, okay, you did the pickup, you transfer it, and then we'll go away. But it is entirely up to the clinician, I think, to take the decision. I think there is no obvious advantage of accepting or setting up an all freeze-all policy for all the cycles with the intention of improving just pregnancy rates. It has to be individualized.
Very true.
Fully agreed.
Sonia ma'am?
We are actually, yes, it became very fashionable a couple of years ago when everybody was trying to do this. But we have gradually learned that just as we were talking about the blastocyst transfer, this is not to be used as a freeze-all policy. Every embryo should not be frozen. We have selective patients, like Dr. Mangoli has mentioned. Something goes wrong with the stimulation and you feel that you can't, and it was actually started to prevent hyperstimulation, OHSS. So that was the reason why this thing was, began for the hyper responders. But we cannot probably use it for all the patients because they may not do well, one with freezing. And of course, we now know the epigenetic problems that we have with the frozen embryos once the babies are being born after the frozen embryo transfers. We are learning that it gives rise to different problems, as Dr. Srinivas has mentioned. So therefore, I think science takes its own time for us to understand it. And as we understand it, we keep on evolving and changing. So freeze-all doesn't hold true anymore. Now we do not freeze-all. We are selective. And as Dr. Kuldeep said, we have to individualize. If we are individualizing our stimulation protocols, we have to individualize the whole IVF cycle. So therefore, even this part has to be individualized. The luteal phase has to be individualized. Hence, no longer freeze-all.
Very true.
Actually, there is a trend that whatever new comes, many clinicians straightway without analyzing, and it becomes a trend sometime. But usually in long run, it doesn't hold true, and you have to come back to the real scenario and decide about the policies that you say in practice.
Yes, Alex.
Yeah, just one more thing that I want to add. Recently, there was an interest because nowadays we are getting a good chunk of papers from the Chinese IVF clinic because of the huge number of data. Yeah. And I saw one study that published in Human Reproduction, approximately 1 lakh patients. They compared between a single blastocyst fresh transfer versus single blastocyst frozen embryo transfers. And the live birth rate was better in the fresh blastocyst transfer compared to the frozen. And they correlated that with the nitric oxide, sulfur dioxide, and ozone presence in the IVF laboratory. And they're telling already when you culture to the blastocyst stage, because of the environmental, this pollutant, it is already a kind of a stress level. So when you expose them to cryoprotectant or freezing, that is going to be an additional level of kind of a cryo injury or a stress level. That's why the frozen blastocyst transfer was comparatively less in sexes compared to the compared to the fresh blastocyst transfer. Maybe this is a valid, especially in many places in our country too, where the pollution is very high.
Absolutely. Absolutely. So the Cochrane review also endorse your views because it was all started with the prevention of OHSs. And in this study, the primary outcomes they studied was cumulative live birth rate and OHSs. And secondary outcomes were the effectiveness outcomes like ongoing pregnancy rate, clinical pregnancy rate, and as you mentioned, time to pregnancy, and also the safety measures like the obstetric and perinatal and neonatal outcomes. And they examined all research published up to September 2020, that is last year, and included 15 studies in the systematic review and 8 studies in the meta-analysis group. Total women included 4,700 odd, and they observed that there are little or no difference in cumulative live birth rates as mentioned by all the panelists and ongoing pregnancy rate. You can see here the conventional IVF program, the cumulative live birth rate was around 58%, whereas with freeze-all policy, it was between 57 and 63, so no real difference. Then OHSs, it may appear that there is a slight reduction in freeze-all policy, but again, as mentioned by our clinician friends, that it may be subjective because you can see whether it is going to be an OHSS case or not. So that can be used in selective patients. So the outcome is uncertain. I mean, the reviewers were uncertain whether the freeze-all strategy has any effect on the risk of miscarriage, multiple pregnancy rate, and time to pregnancy. In fact, what you mentioned Alex, that in recent publications they are having some doubts on the frozen transfers. So evaluated differences in risk for mother and child, and the freeze-all strategy may increase the risk of hypertensive disorders of pregnancy, risk of having a large for gestational age baby, and may result in a higher birth weight of the children born. So, but the study is based on very low number of events. So the quality of the evidence is of moderate quality and for cumulative live birth rate and low quality for safety outcomes. So we need more robust studies. Related to the previous discussion is day 3 versus day 5 freezing, and I think we have discussed a lot about this.
I think we can move to next question.
Yeah, because we are running short of time, I think. So we have another very important thing, but yeah. I would like to ask very simple questions on this because we have many experienced embryologists come clinicians. So what is the difference? I mean, day 3 versus day 5 freezing. Is there any difference in the stress tolerance of the embryos, or the technique is different? Sharma sir?
Yes, it's a very pertinent question, because day 3 embryos where the blastomeres are bigger cells, and in a blastocyst, the cells are smaller. So definitely they have a different stress tolerance. So the technique of freezing, the duration to exposure to the, the freezing media would also be different. And as far as survival is concerned, in good hands, I think whether you do day 3 or day 5 freezing, it would be the same. But in my point of view, if I freeze embryos on day 3 And then before transfer, I let them grow to blastocysts. So I would also be, assessing them not only morphologically, but also the functional aspect of the embryos. So that would be a better choice for me to freeze at day 3 and then let it grow after the thawing, day 5, and then choose the best embryos out of that.
Any other comment from any panelist?
Yes, absolutely, absolutely right. As Sharmaji is very rightly pointed out, there is a slight technical modification is obviously required because due to difference in the surface area to volume ratio and the tolerance capacity of in how fast the cryoprotectants enters and leaves the cell. It is very important. But once achieved, then the post-warm results, they are comparable. So you need some practice to evaluate how you're going to get those particular the exposure to the particular ES solution, and then judge it properly and then go for the vitrification. That can be done. And second point is also very valid, because in day 3 freezing, you can warm it, say half day early, you can check its viability. Even if you do want to do it on day 3, then also you can check its viability actually and then transfer. But the same thing may not be true if you freeze expanded blastocyst. You have to thaw it on the same day and then transfer it. So that slightly blind approach may be there, and day 3 transfer is slightly getting an upper hand over the blastocyst transfer for this reason. I agree with that.
Sir, what is your preference? You are doing same day transfer, or you are letting them grow and then transferring? Like day 3, if you are doing a day 3 freezing, you are transferring on the same day or a day later or 2 days later?
Well, I think it depends upon what is the quality of the embryos are frozen. If all the 3, for example, if I have frozen 3 good grade 1 quality embryo on day 3, I certainly want them to go to blastocyst and then thaw it. But if it's a combination of, say, grade 1 and grade 2, then there's no point in waiting and there's no point in taking a chance, because it may result in no blastocyst and therefore no transfer.
Here I would like to mention my experience, because I'm doing all stages vitrification, and in fact probably I started way back when I used to prepare my own media and my own device for vitrification, and I found that the pregnancy rates, especially clinical pregnancy rates, were similar with all these stages, and I have never frozen a chunk of cleaving stage embryos in just one device. So because I was confident that my survival is good, so I never froze more than 3 cleaving stage embryos in one device. And at different centers, the operator, that is me, is same. But I have seen that at one place where we have day 5 policy, and at another center where we have a flexible policy, our rates are similar. So, I mean, it is quite obvious that we have to have a judicious decision-making process in place. So, I think this is going to be an exhaustive session now, because it is a very important topic, and we have heard Rajvi Mehta talking on this. We have also heard Dr. Ratna ma'am describing the effectiveness of add-ons. So there are various advanced sperm selection techniques, and I have taken especially one Cochrane review, and I'm going to ask you the questions based on that. So there are different advanced selection techniques we have, to start with, like HAXE and sperm slow and MAX and microfluidics and zeta charge selection. So first I would like to ask how many of us are actually using them in our routine practice. To start with Vijay.
Okay, out of this, whatever has mentioned, I had used hyaluronic acid as well as the microfluidics. The rest of the three I have not used it, so I can talk based upon those. Even hyaluronic acid, yes, I had used it and found slight improvement in the pregnancy rate, particularly when I had previous history of the DNA fragmentation of the patient. But here also the second thought is that I may be introducing some more stress on the sperms during selection. This is what I think. The second part, microfluidics. Yes, I have been using microfluidics for quite some cases, but here what I found the major difference, of course I had used only one type of the instrument that is used, but here I have found a drastic difference and one significant outcome. Immediately after using microfluidics, the output is excellent. You get literally hyperactive sperms as compared to the swim up, because I compared that to swim up and the density gradients. So as compared to both other, microfluidics did give me a very excellent kind of the output, almost 100% motile. Plus the main difference was they were very hyperactive. So I was very happy to use that. But at the same time, for some strange reason, what I found was their 24-hour survival was very, very poor as compared to other two. And plus, of course, I had used for 2 patients, but in 2 patients with microfluidics, I did not get good fertilization with the conventional IVF, not with the ICSI. With ICSI, I got very, very good results. So this is something that is worrying me. Of course, I have very limited numbers to talk about for this thing. I may ask other panelists, Varghese or anyone who has similar kind of experience of microfluidics with conventional IVF.
Yes, we used the microfluidics in the beginning, but only thing that we found was that the sperm that is selected, we found that the size of the sperm head, we found that during the ICSI time comparatively a little bit less compared to the conventional gradient selection. So I was thinking maybe it is the fast moving sperm, maybe the one with a less density or something like that. Maybe that could be on a, but that was a good information. Dr. Vijay has mentioned that the fertilization failure happened in the conventional IVF. Maybe the acrosome is less in that group that is selected to move fast to the interface, something like that.
Right.
And,
somehow
yeah.
I feel that it has some kind of methylxanthine derivatives type of reaction where the motility is gained too fast, and then it decreases. This is what my thinking is. Of course, I have to do more cases to do that. That's why I just want to know your opinions. Anyone else is using microfluidics here?
In fact, I have used a lot
Yeah.
as one particular type of device. That is good enough for ICSI only, and not for conventional IVF. So, but another variation of this, because I seen a recent publication comparing direct swim up with the other like microfluidics and all. So I have done a few insemination with the direct swim up when it was a normozoospermia, and it was a relatively cleaner sample, so there was less risk of any microbial contamination. So I did, because you get a beautiful cloudy interface when you have a very good normozoospermic patient, and if you inseminate with that, I could achieve similar fertilization and embryo development rate as we did with other techniques. But yes, I do not have any experience of conventional IVF with the microfluidic devices, because I have used just one type of device.
We have Dr. Jayant Mehta is here. We can ask him if he can put some light on that.
Dr. Jayant Mehta, sir, can you come up, please?
I think we have to allow him permission to.
Yeah, so meanwhile I can ask another basic question.
Yeah, he's open that. Yeah.
Hello, can you hear me?
Yes,
yes. It's a very interesting discussion that's taking place about selection using microfluidics. I have been using microfluidics, and my experience has been similar to, initially it was similar to what was mentioned earlier, that the fertilization rate with the conventional IVF was less compared to the ICSI. However, since changing the chip, and the Zymote chip is what I've been using, I have now recovered the similar results of fertilization for conventional IVF and for ICSI. However, having said that, what I have noticed in my observations of the embryo development to blastocyst stage, there is a slight difference in terms of the quality that I'm achieving with my conventional IVF compared to the ICSI. Now, at this particular stage, I've not been able to evaluate why there is this difference. And I'm sure that there is some mechanism which would allow me to identify that. But what we have also done is we have also looked at the aneuploidy of the sperm that swim up in microfluidics compared to the conventional methods that we have used. And the aneuploidy rate of the sperm has been significantly less compared to density gradient separations or the swim up. So obviously, I don't have enough information or enough data to compare and give this, to give a reason why this is happening.
So have you changed the company of the microfluidics or the same company you're using, Zymote?
No, I'm using the same Zymote, but what I've changed and what I do is I allow my sperm to swim in HIPPI's MOPS-based dual buffer. I don't use a bicarbonate buffer because I use a dry incubator for them to swim through, and it gives me a larger pH, pKa value of my fluid for the sperm to swim and recover. And it's only done for 30 minutes. So whether there is that difference, I'm not quite sure, and I need to evaluate that further.
Okay, that's a good information. Thank you. Thank you, Dr. Jain.
No, always welcome. Thank you.
So I was asking about the difference between like what we use for PICSI or HAXI. We are using hyaluronic binding, and sperm flow where we are using hyaluron to select these sperm and injecting with this. So what is the basic difference between these? Sharma sir?
Yeah, basically, HAX is done on a petri dish, where there is a embedded hyaluronic acid is there. So the sperms go and, stop at that place, and, you can see them shaking over there. While in the sperm slow, it is a, highly viscous sample media containing the hyaluron. So that would slow the, the normal sperms more. So you pick up those sperms and then use them. So basically, it is almost the same. Only thing is there you have, small spots on the petri dish itself where the sperms, stop themselves because they love hyaluron. And you can, see them, the tip of the head, attached to that drop and then, shaking their tail as they do it with the Zona pellucida. If you, just watch the sperms under high magnification, the same kissing goes on there. So you just pick up that particular sperm and then use it there. And another thing I want to just say about this theta charge sperm selection, though I have no, experience, but what the literature I've read, it can change the, sex ratio of your. So in India, you should be very careful because when you have to give to the PCP entity, you may get a problem over there.
Absolutely true. They are just waiting.
Yeah. So do not please advertise.
Yes.
Even if you're doing it, otherwise they will catch you on that only.
Right.
Very true. So we have this beautiful review on the advanced sperm selection technique, and I think this was in 2019. And the review question was to determine if any advanced sperm selection technique used for ART, except ultra high magnification, so we did not discuss IMSI, alter the rates of live birth, clinical pregnancy, miscarriage, or fetal abnormalities. And they included 8 RCTs, Then 4 studies were based on the comparison of HA-ICSI versus conventional ICSI. 3 were based on MAX versus ICSI. Only 1 study compared HA-ICSI versus SPUMS-Slough. 1 study compared HA-ICSI versus MAX versus conventional ICSI. And 1 study was based on Zeta SPUMS selection. 7 studies included clinical pregnancy, 6 included live birth rates, 6 included miscarriage per clinical pregnancy and per woman, but none of them they really discussed about the fetal abnormalities. And the results you can see conventional ICSI versus PICSI was almost similar, so the low quality evidence and only 4 RCTs were included in this. Then 2 RCTs, they compared the conventional ICSI with HA-ICSI about the live birth rates. So again, very similar, 25% versus 24.5 and 31%. Then the miscarriage rate per woman, 3 RCTs in they studied this. So again, there was a very slight difference if you look at the data, 7% versus between 3 and 6%, but it was of low quality evidence. Miscarriage, again, there was slight inclination towards the PICSI, but we need more data. HA-ICSI compared to SPUMS-Slough. So what the reviewers concluded that they were uncertain whether HA-ICSI improves live birth rate or clinical pregnancy. The quality of evidence was very low. They were also uncertain whether it reduces miscarriage, I mean the PICSI, per woman or per clinical pregnancy rate. So the risk ratio and 95% confidence interval, it was mostly similar. MAX versus ICSI, again similar results, uncertain whether it improves live birth rate or clinical pregnancy rate. They were also uncertain whether it reduces miscarriage. Zeta SPUMS selection, because it was based on just 1 study, though they were uncertain of the effect of SPUMS selection on live birth rate and clinical pregnancy rate, they were also uncertain about the reduced miscarriage with this. MAX versus PICSI, again, there was only 1 RCT and it did not report on live birth rate, but uncertain of the effect of on the clinical pregnancy. The study, the reviewer were also uncertain if MAX really reduces miscarriage. So author's conclusion on all these advanced sperm selection techniques were the evidence suggests that sperm selected by PICSI may have little or no effect on live birth rate or clinical pregnancy, but may reduce miscarriage, as also mentioned by one of our panelists. We are uncertain of the effect of Zeta sperm selection on live birth rate, clinical pregnancy, or miscarriage, principally to the low quality of evidence on this intervention. We are uncertain of the effect of the other selection techniques on live birth, miscarriage, or pregnancy. Further, high quality studies, including the awaited data from identified ongoing studies, are required to evaluate whether any of these advanced selection techniques can be recommended for use in routine practice. So, most of the things we all agree on, that any new intervention or anything that is new should be evaluated basically first on do no harm, and then we can also weigh the advantages and disadvantages as far as the cost and effectiveness is concerned. Here is just one slide. We are of course we do not have enough data on this, but I would like to ask our panelists, what do they think on the future of this selection technique like deep learning, machine learning and AI?
Yeah, this is really an evolving field. I know one group in Mexico, along with Professor Dr. Jack Cohen, is working on selecting the sperm at the ICSI table workstation itself based on the flagellar pattern and the movement. I think that work, maybe because we are having limited tools to select which is a good sperm. And there is, because one of the major issue nowadays is the sperm DNA fragmentation. And we have only limited tools to take the live sperm for ICSI. Maybe in future, maybe some kind of optical system will come up along with the machine learning platforms so that can guide us to select the best sperm to fertilize the egg. It's a really promising area. Maybe it will take another 5 to 10 years, maybe.
Yeah, because what I was wondering, even if we give enough algorithm and data to the machine, what we can give best is because we are selecting sperms basically with the light microscopy. So whatever data we can provide on the images of the sperm, if you are evaluating a live sperm based on those data, limited information of the morphological normalities or abnormalities, how it is going to detect a DNA fragmentation, DNA integral sperm. So it is what I think. Any other thought?
Absolutely right. There is a lot of scope, as Alex mentioned. See, the thing is that whatever tests that we opt for, we think that that information should be available, whether it is aptosome reaction, whether it is mitochondrial activity, whether it is nuclear chromatin decondensation, or it is a DNA fragmentation. All these tests are invasive tests. The sperms on which you perform it, you can't use it actually for the sake of fertilization. So if we get any kind of technology, by any means, if we can select it without harming that particular sperm and then get that information on screen, and while doing the ICSI, I think nothing like that, and AI will play a very, very important role into this. That is what my prediction. And very rightly said that within the next 5 to 10 years, I think this is going to happen.
The concept is very, very good. Only thing, how to integrate all information in the system, that may take more time, because some of them they are easily available, but the data on DNA integrity and other aspects may not be available freely for incorporating into the system. So that may take little more time, but yes, concept is very, very good. If we have something like this, then it will be really useful.
Sharma sir.
Yeah, see, under the circumstances, we are talking about futuristic. What can we do today? This is just, I wanted to say a few words. Firstly, we ask the patient to have a lifestyle modification. Then we check their ROS and DNA fragmentation. And after that, prepare the semen sample by density gradient, expose them to the PIXI dish, pick up the sperms, do the IMSI, find the best sperm, and do the ICSI. I think under this, present available technology, can help the patients. Rest, artificial intelligence would be the future. Yes.
Any other comment? Ma'am, you are laughing on this.
I'm not laughing. I'm just saying, even for artificial intelligence, it's going to take a while, because as far as artificial intelligence doing blastocysts today, it's a different issue. It's a single entity, but here we have got millions of sperm swimming over there. To do a selection out of that is going to be a challenge even for artificial intelligence. So I mean, I don't know, maybe we could pick up a few and then start doing it, but I'm sure it is the future.
True, very true. So, my co-moderators, any comments? Please
Yes.
unmute.
Unmute.
Dr. Ved.
Unmute.
Sorry. As rightly said by all the panelists that yeah, this is the future, but it is definitely very difficult to select single stump out of that, and that DNA integrity is right or not. So I don't know, but yes, it is a future now because in embryo selection we are using this and we are getting somewhat good result out of this. Thank you.
All right, so we have this recent Cochrane review, and they have reviewed all the literature available. It is recent, I think 2021 or 2020, and it says all about the IVF add-ons. And as we all discussed and we all agreed on, that although there are many different add-ons available, none have been evaluated in high quality studies. And there is some evidence, but it is not high quality, that 3 of these add-ons may benefit people, like the use of PIXI or adding hyaluronic acid to embryo transfer media, then the injection of HCG into the womb. So these 3 modalities may improve a little, but still we need more studies. And there is a little paradox, I mean, because at one hand we all read that these Cochrane reviews, they advise that we have limited data and we need more studies. So sometimes the practitioners, they get carried away that no, this practice should not be done in my clinic, or so unless we do them, we do not have enough data. So we have to be judicious. We have to be very selective in our patients when we are offering these new modalities or newer techniques. We have to give very good counseling to them. And I believe, because we have mentioned multiple times that there are certain legalities included, so we should have their written consent on using those techniques or offering those techniques and modalities. But the take-home message is very clear that we have to be judicious. We can use those things, but in select patients, not in all. And again, this is very commonly used graph that the marketing and sales people use, that if anything new comes, there is a hyper response to that and everyone rushes towards this and it gets a hype, then it goes down, and again when we have more evidence to endorse or to advocate that particular thing, there is a slope of enlightenment, and then plateau comes where we accept with its limitations and when we start using it more judicially. So with this all, I thank all my panelists, all my moderators. We had many more questions. Dr. Ved suggested me at least 9 to 10 more things, but I think it needs another webinar to discuss all those things. So thank you very much, and I hope our listeners, our viewers have gained enough knowledge to take home and practice them in their day-to-day practice. Thank you very much, Sonia ma'am, Kuldeep sir, Sharma sir, and thank you very much all my panelists, co-moderators, Dr. Ved and Dr. Neelam Bapna ma'am. Thank you.
Thank you. Great moderation. Really enjoyed the panel. Thank you very much, all of us. Thank you.
Thanks, Ved and everyone, Dr. Sanjay. It was really wonderful listening to all great embryologists here. It was really wonderful.
Over to Sanket.
Yes.
Rahul, I think Rahul
Sanket is missing.
Okay, Rahul, you can take over.
Yes. Thank you so much, panelists and moderators, for bringing out this panel of so much interest and of great knowledge. I would like to now invite Dr. Charudat Joshi sir for vote of thanks. Charu sir is here.
Sir is there.
Charu, are you there, Charu?
Thank
Sir is logged in.
Anyway, Dr. Shukla, can you please share?
Yes.
All right. So I formally thank all the great teachers, Sadhana Desai ma'am, Ratna ma'am, Rajvi, and the moderators, conveners, K.D. Nair sir, Bindu Mehta, and Charudat Joshi. I would like to especially thank Dr. Jayant Mehta that he joined us without any hesitation in conversing with us. And of course, MCure, the entire team, Deepak.
It is Jidus, sir. Jidus.
Sorry, Jidus. So Deepak and his team who brought about this wonderful event today to our viewers and listeners. Thank you very much on behalf of iHera.
Thank you. Thank you.
Thank you, everyone. Thank you. Thanks a lot. Thank you, Sharma ji. Bye.
Thank you. Nice seeing you.
Yeah, very nice.
Younger and younger.
He's Anil Kapoor of embryology.
He's the doyen of embryology.
Right.
Thank you very much, everybody. Thank you.
Thank you, Ratna ji.
Thank you. Thank you.
Thank you, madam. Thank you. Nice listening to you, ma'am.
Thank you.
Okay, bye.
Bye.
दीपक रिकॉर्डिंग की है ना तुमने?
हाँ जी सर मैं भेज दूंगा आपको रिकॉर्डिंग. ओके. Thank you, sir. Thank you very much.
Thank you,
Dr. Ved.
Thank you, sir.
Dr. Ved, thank you very much. Dr. Shukla, thank you very much.
Sir, welcome.
Thank you.
Thank you.
I hope you have improved on your breathing difficulties.
Yes. It's much better now.
Right.
Dr. Shukla is much is cleared up. So obviously, there's no hesitation now to sort of speak in that respect. Thank you very much. And I must recommend, recommend and sort of congratulate the entire HiRA team, especially both of you and Dr. Charudat for an excellent presentations and the coordination of this day's webinar. And we all learned a lot. Thank you very much.
Thank you.
And finally, happy Teachers Day to all of you.
Thank you.
I learned a lot from you people. Thank you very much.
Thank you.
Thank you. Bye-bye.
Bye, sir.
Bye-bye.
Thank you, Ved sir. I'll end the session and I'll send you the recording as well.
Okay.
On e-transfer. Thank
Bye,
you, sir. Thank you, Shukla sir. Thank you, Ved sir.
Bye, Rahul.
Bye.
राहुल तो अभी फंसा हुआ है अंदर. तुम लगे रहो.
सर बस आज तो मैं भी बीच में इतनी देर वेट कर रहा था. मैं अभी हो तो मैं करके निकलता हूँ. फिर अंदर से तो कॉल ही